Can you see my slides?
Yes, we can.
Okay. Thank you, Evan. Very kind words. I wish my wife was listening, so it would go a long way at home in order to get through the COVID issues. I appreciate the opportunity to talk about innovations in interventional cardiology, which have had the greatest impact in congenital cardiology. I don't have any disclosures, but I do have a disclaimer. And that is when Evan asked me to do this talk, I thought it was going to be easy peasy, that figuring out what procedures or people have done the most in our profession, in our community. But as I thought about this more, I asked myself the question, how can we identify which innovations have had the greatest impact on the field? And importantly, what is the relationship between innovation and invention? So I asked a couple of friends to list for me what they thought would be the most important innovations in our field. But in its purest sense, invention is the introduction of a device or a procedure for the first time, while nothing is happening. Uh-oh. There we go. Innovation, on the other hand, occurs if someone improves or makes a significant contribution to a device or a procedure. So in many ways, innovation flows from invention and vice versa. It's a circular type of relationship between an invented device or procedure and a change in its innovation. And the ancients were absolutely true. This quote is attributed to Bernard of Chartres in the 12th century. "We are like dwarfs on the shoulders of giants, so that we can see more than they." Indeed, it goes back many, many more years. The Greeks had the same concept, that other people's work are the foundation of what we do moving forward. So as an outline for today, I thought I would give a brief historical introduction to the place current progress has made, put it into perspective, and highlight two things. One, innovations that have helped our patients avoid surgery, and innovations that have helped us. So I think when we begin about the history of interventional cardiology, you have to begin with Rubio Alvarez and Lehman Larson in Mexico, when they used a urinary catheter with a guitar string to saw open a child, a 14-year-old with a pulmonary valve stenosis. But it wasn't until 1966 when Miller and Raskin published the landmark article on the creation of an atrial septal defect, altering the life history of babies with transposition, allowing them to survive long enough to have a surgical correction in the early mid-60s. Chuck Mullins wrote that the initial response to this report varied between admiration and horror. It stirred the imagination of cardiologists around the world and set the stage for all future intracardiac procedures. Now, 55 years later, the procedure, as described in that article, is almost unchanged, and it's been applied in, transposition, areas to decompress the atrial hypertension, and diastolic and systolic heart failure and pulmonary hypertension. Portsman, of course, did the first corrected congenital lesion in the cath lab, but the sheaths were very large. King and Mills did the first corrected intracardiac congenital lesion. Of course, the delivery system was very large. And around the same time, G and Turco developed and used these fibered coils, which were quickly taken on by interventional cardiologists for abnormal vascular structures in congenital heart disease, and ultimately the patent arterial duct. Now, Ryashkin in 1979 wrote an article trying to demonstrate closure of the arterial duct using a hook device, fish hooks, if you will. It was a bit edgy. It tended to catch on a lot of things other than the arterial duct. And he quickly innovated with this double disc device called the Ryashkin occluder. But the real innovation in its application was Chuck Mullins in the mid and late 80s, because the delivery of this device was difficult, retrograde, and the innovation of using a long sheath and a transvenous application changed the way we approach congenital heart lesions and influenced other techniques moving forward over the years. Gene Kahn, of course, in 1982 had this landmark paper, The Explosion of Interventional Procedures Using Balloon Technology, based on the work of Dotter and Grunzig, in 5 children with valvular pulmonary stenosis. And this laid the groundwork for the VACA registry and the application of balloon valvuloplasty, not only in pulmonary valve stenosis, but aortic valve disease, peripheral pulmonary artery disease, coarctation, and recoarctation of the aorta. It didn't take much time for pediatric interventional cardiologists to apply the technology of the balloon for the cyanotic newborn, initially tetralogy of Fallot, balloon dilating the patient with valvular pulmonary stenosis. But it was Sheikh Qureshi in the late 80s, early 90s, who used an excimer laser to address more complicated lesion, that of pulmonary atresia tac septum, really a game changer in many of the approaches that we use for congenital lesions. Now, the application of stents was actually something that Chuck Mullins had led the way, having developed a relationship with Julio Palmez in San Antonio. He was able to see the application of these large endovascular devices, the endovascular stents, in pulmonary artery stenosis, which rapidly changed or expanded to arch coarctation and right ventricular outflow tract obstruction in conduits. And then it didn't take much time before the concept of covered stents or covered implants, with the advantage of protecting the wall, were made available based on the concept of the bare metal stents. And then, of course, it expanded the application into arch coarctation for safe implantations and protecting the wall. The cath lab Fontan, which John Cheatham and I had some brief experience with, and of course, work that Shaq will talk about later in looking at the sinus venosus ASD with the application of covered implants. I just thought it would be interesting to hear Dr. Palmez speak about how he came about the idea of the slotted stent. He had gone to a meeting by Andres Grunzig in the late 70s. And Grunzig was speaking about the limitations of balloon angioplasty. And Dr. Palmez, who had just finished his fellowship in interventional radiology, said, well, maybe there could be a scaffold that could support the vessel so it didn't recoil. He tells the story that it was quite by accident. He found a piece of metal, a metal lathe in his garage floor at home, the kind that makes the masons use to put plaster on. And the pattern on the material was staggered openings. And he thought, well, it looked like it was something that he was trying to do. He grabbed the device, cut it into small pieces, and then pushed it together, and describes bouncing it on the table with a hammer. And he realized that the staggered openings were actually staggered slots when closed. And he thought, well, If you can make that pattern in a tube, then when the balloon expands, it would become a mesh. And it can be made from a single material. And that's the inspiration for the slotted initial Palmaz stent. These stents found application, again, with the pediatric interventional cardiologists in the cyanotic newborn, an application for the neonate with tetralogy of Fallot or tetralogy of Fallot and pulmonary atresia, applying RF perforation to open up the valve, the arterial duct, whether that was single or dual source, and in the hybrid single ventricle management strategies, and of course in Blalock-Taussig Thomas shunts that are occluded after surgery. Now, Bill Rashkin in the 1980s also developed a hooked ASD device, which tended to hook on everything but the ASD. I think there were 4 patients that were tried or had this accomplished with, I think, Bill Hillenbrand and Jim Locke and Dr. Rashkin were involved, and Chuck Mullins. But it became clear that the concept of a hook device inside a single disc hook device inside the left atrium was not as safe as one had hoped, particularly with the understanding of the anatomy that was at the time. And Jim came up with the idea of a double disc device, initially the clamshell, which evolved in the CardioSeal and the Starflex and the BioStar over the years. Again, the double disc implant, and it was the use of the memory metal nitinol that changed the approach of closing atrial defects by crude implants, where now I'd say more than 80% of the defects can be closed with percutaneous devices based on a nitinol framework. This nitinol material, nickel titanium, which gets its name from its component parts in the Naval Ordnance Laboratory, morphed into a variety of different designs from a number of different companies, which then allowed us the ability to close a variety of ventricular defects, ducts, vascular occlusion, paravalvular leaks, and the preemie duct, which will be addressed in lectures later this morning. It's interesting that Dr. Grunzig had such an impact on interventional cardiologist Henning Anderson in the late 80s, had gone to a lecture by Dr. Grunzig. And at that lecture, while Henning was still a cardiology fellow, he said to himself, well, why does things have to be done by a surgical approach? And he created this device, this stent-based valve that he thought could be implanted percutaneously, which he was able to do in a number of large animals, pigs. Unfortunately, it was 41 French, so the technology, the concept was there, but the technology wasn't. But it was in the late 90s, year 2000, that Philip Bonhoeffer, based on the experience of percutaneous stenting in stenotic conduits, came up with the concept of utilizing the stent framework inside supporting a category graft, which has led to what has been also a game changer in our profession, with very, very good hemodynamic outcomes in eliminating regurgitation and reducing stenotic gradients in conduits. Of course, that was a small minority of patients that could be take advantage of that technology, although globally, and this was in 2017, where this data came from, I think there's more than 14 or 15,000 implants using the Melody system around the world. But it didn't take long for investigators and engineers to address the larger right ventricular outflow tracts of the tetralogy population with a variety of different device sizes and shapes, which we'll hear to later this afternoon in the detail of their clinical application. Finally, I wanted to tip my hat in terms of innovation to Mike Tynan. First, in human, the concept of percutaneous or per uterine fetal interventions for aortic valve stenosis, which has been applied to the pulmonary valve, and the atrial septum, and hypoplastic left hearts. Really an innovator. That concept has developed into an entire subspecialty of fetal cardiology and fetal intervention. Now, just a couple of words on interventional interventions that I believe actually help us. I think that the development of vascular ultrasound has made access to the vessels in tiny, tiny babies much safer and easier. The use of closure devices in their application for large bore vascular entry has changed the way and the conduct of the catheterization. We'll hear about 3D modeling. I think that the use of overlay infusion in the catheter laboratory, 3D rotational angiography in preparing the procedure and understanding the details of relationships of the vessels during the procedure and their application, for example, in coarctation of the aorta has been really changed the way that we approach patients in the laboratory. Imaging in the laboratory, TEE, intracardiac echo, certainly have made our life easier in trying to do procedures with complex anatomy. And finally, stuff that I like that has made my procedures much easier, the Gore dry seal, its application in valve implantation, the DeVille sheath, which is very stiff, non-kinkable sheath, and pre-mounted covered stents, making application and delivery very, very easy or easier. And finally, stuff for us and for our patients, I think, is the understanding of radiation safety in the catheter laboratory has really, in the last 5 to 7 years, taken a forefront in the way we approach patients and patient investigation. So I just want to leave you with this one quote from John Sackar, Legitimacy in the Modern State. The future is not some place we are going to, but one we are creating. The paths are not to be found, but made, and the activity of making them changes both the maker and the destination. So with that, thank you very much.
Thank you so much, Lee. That was, as expected, a phenomenal talk, and we really appreciate you giving that to all of us. I'm going to turn it over to Grace Van Leuven, who has some instructions for all of the participants. Grace?
Hi, everybody. And I just want to welcome you all to Congenital Heart Academy. We are really happy to have all of you and these amazing speakers. Thank you very, very much. Just a quick Zoom information. So for you not to have your screen with the speakers in front of the presentation, you can go to the view options and then you click on side-by-side mode. And this way you won't have, you're going to be able to see the entire presentation. And the other thing is that you can choose the speaker view or the gallery view. If you choose the speaker view, you're going to see only the one who is talking. If you choose gallery view, you're going to see more than one person. And please talk to us. We want to talk to you on the chat. So when you use the chat, please click all attendees and panelists so everybody can see what you are writing. And please make questions on the Q&A, and all the speakers will try their best to answer you during the talk. Okay, thank you very much. And Dr. Zahn can talk to you again. Thank you, guys.
Coming. It gives me great pleasure to introduce actually our moderator for the day. Dr. Giulia Gagliardi is the director of the Adult Congenital Unit, the Gooch Unit, and Bambino Gesù Children's Hospital in Rome, Italy. And she is also a consultant in the catheterization laboratory. And Giulia is really going to take over and lead us for the rest of the morning. So I'll turn it over now to Giulia.
Good morning, everyone. First of all, let me thank the organization, Grace, Sasha, Gail, Evan, for the invitation. And it's my pleasure to moderate this session, introduce to the audience the speakers. First speaker is Yoav Dori. Hi. Yoav.
Hello.
Hi. I saw you some months ago in Rome at Bambino Gesù. Do you remember?
Yes.
Because you treated the patient after Fontana operation. Now he's doing well, but we fenestrated the Fontana percutaneously. So, Dr. Dori is a pediatric cardiologist and director of the Giulia Mark Fisherman Center for Lymphatic Disorders at the Children's Hospital of Philadelphia. His team has already discovered the lymphatic role in a handful of complex disease affecting patients with congenital heart disease, including chylothorax, plastic bronchitis, and PLE. His work is centered on developing new lymphatic imaging and interventional techniques, and to clarify the role of the lymphatic system in diseases affecting patients with congenital heart disease, and to better understand the interface between the lymphatic and cardiovascular system. Thank you.
All right, let me just a second. Get this going. All right, can everybody see the screen?
Yes, we
We're
can.
good?
Yes, we can.
All right. All right. So first of all, thank you to the organizers for inviting me over here. It's really a pleasure to see everybody again. A shame we can't see each other in person. And given the numbers in the United States right now, I don't think we'll be seeing each other for about 5-6 years. I don't really have any disclosures except for to say that given that Matt Gillespie is now my boss, if anybody's looking for an interventional cardiologist, call me. So we'll talk about lymphatics today, which is most of what I do these days. This is just a general introductory slide to the lymph system. In general, it's obviously it's a circulatory system. Flow in the system is from peripherally, centrally. Two main streams for lymph flow are the liver coming from, as you can see over here. Can everybody see the mouse when I'm pointing? Yes, good. And the intestine coming from over here that constitute about 80% of the flow in the thoracic duct, which in most people drains to the innominate vein on the left side, although there's a lot of variability in that. Flow in this circulatory system is about 2 to 3 liters a day in a normal person, and it can be up to 30 liters a day in a patient with heart failure. So quite a significant difference. Many things affect lymphatic flow and the circulatory system. Basically, everything that we do in the ICUs, all the medicines that we give, they all have effects on lymphatic circulation. We don't know all these effects yet, but we will, with time, learn them, just like we've learned the cardiovascular system. But one thing that we as cardiologists have to be mindful of is the problem of CVP, which affects our entire cohort of single ventricle population, but many other patients with tetralogy of Fallot and other heart failure. So when you're born, you have normal flow from the liver mainly and normal drainage. If you are a Glenn, then once you do the Glenn operation, you increase afterload on the thoracic duct. And at that point, you're starting to cause lymphatic congestion because the thoracic duct can't drain easily. You still have normal production. So most people at the Glenn stage don't show up with a lot of problems, although we do have a larger cohort of Glenn patients now that we are treating with chylothorax and other abnormalities. When you take a Glenn and convert it to a Fontan, now you have increased CVP everywhere. So your liver starts to kick in enormous amounts of lymph, and that is really the #1 producer of lymphatic in patients with heart failure. And you still have the problem of decreased drainage, and now you have two problems that the lymphatic ducts don't know how to deal with very well. So you start to see congestion, and you start really to see the problems. But in addition to that, we know that in our patient population, there is some kind of a channel problem, because some patients with high CVP don't have a lot of lymphatic congestion. Some patients with relatively low CVP have very severe lymphatic abnormalities. So there's some genetic susceptibility, and the combination of the abnormal physiology and the abnormal channels ultimately leads our patients into lots of trouble. Almost all single ventricle patients, ultimately, if they survive long enough, are going to develop lymphatic failure. What really has allowed us to really start to develop new interventions is these imaging modalities that we've kind of developed over here. One of them is intranodal lymphangiography, which I have taught now many of you out there, and anybody who wants to learn needs to come over here. Really, any interventional cardiologist, this should be the basics of lymphatic imaging. All of us should know how to do this. It is a really simple technique and is very important for diagnosing the pulmonary or thoracic lymphatic abnormalities. This is accessing lymph nodes in the groin. This is what a normal intranodal lymphangiogram looks like. You can see both anatomy and flow with this technique. And you see a thoracic duct going up over here and draining to the left. There's two additional imaging modalities that we've now introduced. There is intrahepatic lymphangiography, which we do in all single ventricle, but actually all patients with heart disease coming in with multiple compartment problems, but all single ventricles, irrespective of what they're coming for, are going to get this imaging modality. And in this modality, we access the liver and put contrast in there. And you can see over here, this is what kind of normal looks like. We inject the liver, the retroperitoneal lymphatics light up, and then the thoracic duct, and it goes to the left. And there's a new imaging modality that we just published about, which is the intramesenteric. I won't talk about it, but has significant implications for patients with ascites and PLE. Well, not enough time today to introduce that. Our patient population, I like to think of that as abnormalities in different compartments. And those who present with abnormalities in the thorax will present usually with these three abnormalities. So either they'll have a chylothorax, chylopericardium, or plastic bronchitis. And we might want to change the terms for this because you can have leaks in the chest that are lymphatic leaks that are not chylous. So we'll call it a lymphatic thorax, lymphatic pericardium, and lymphatic plastic bronchitis. You can screen for these, and everybody who is dealing with single ventricle patients needs to do this. All patients with single ventricle physiology need to get T2 imaging before they get the Fontan. So many centers are now starting to do this. And we published about this because we know that this imaging modality, which is a very simple method to do, you don't need contrast, you don't need anything. It takes 2.5 minutes. And if you have high-grade abnormalities, so you have lymphatic abnormalities in the chest, in the thorax, in the mediastinum, that's what that would be a type 3, and extending into the pleural space, and that would be a type 4. We know that this is what this looks like. So this is this bright signal here that you see. And this is bright signal extending into the lungs. And we know that this abnormality correlates very well with the outcome of these patients. And if a patient has a type 4, they will do very badly. Most of them will not survive a Fontan without doing anything to them. And this is their outcome. So almost all of them, they had high mortality, need for transplant. Only 2 patients of the entire cohort of 13, and now we have a larger cohort, survived the Fontan. And those were doing very badly, so we had to intervene on them. The type 1, 2s, and 3s all do well. Type 3s usually will have more longer effusions, but we can convert them to a good Fontan. They will be the ones that ultimately will get plastic bronchitis. What happens to the type 4s and what interventions that we need to do on them, that is something that we are working on. This is what causes most of the abnormalities in the chest in patients with not just single ventricle abnormalities, all of our patients, because we've now seen in tetralogy of Fallot, TGAs, heart failure. This is the crux of the problem, and this is this abnormal perfusion of the lungs. So when you inject the groins, you can see there's this flooding of the lungs. Things are flowing retrograde over there. Here you can see the airway. So it makes sense that if your airway is being flooded like that, then ultimately it can leak into there. It can leak into the pleural surface. We call this pulmonary lymphatic perfusion syndrome or lymphatic reflux, whatever you want to call it, doesn't matter. There are 5 types of this. And actually, there's now 6 types. I didn't update this slide, but I'll show you what the 6th type looks like. The reason to know this is because our thoughts about how to do interventions in these patients is constantly changing. And if you have these type 1, 2, and 3, that means you have a thoracic duct that is connected to the vein and is draining. And in these patients, you want to try, if at all possible, to not shut down the duct when you're doing interventions. So we try to do selective interventions in these patients. If you don't have a duct connected, then there's 2 options. You can shut down some of the system in order to prevent the problems, or you can now create lymphovenous connections, by surgical procedures, which we've also published on. Those are doable, especially with this type, less with this type. And there's an additional type that I'll show you a little bit later, and that's problems coming from the liver and going into the lungs. One of the things I said, we need to determine the type. So we need to know if the thoracic duct outlet is open. So all patients, after they get their MRI imaging, come back to the cath lab, and this is what we do with them. This is another technique that we've an article should be coming out with this. This is ultrasound contrast intranodal lymphangiography. So this is an excellent technique to confirm thoracic duct outlet patency. And you can see the thoracic duct drains over here, and this is the ultrasound contrast we inject in the lymph nodes, and within about half a minute to a minute, you'll see the contrast coming out over here into the vein. So that tells you the thoracic duct is connected, where it's connected, and that it is draining, and that's very important for some of the things that we're doing. This is the intrahepatic imaging, and the reason why we do this, especially in all the single ventricle patients, because those patients are susceptible to PLE, and we know, we think, and we will be publishing that soon also. We just finished collecting our data on about 30 or 40 patients who had this type of imaging with single ventricle physiology, is that we can potentially detect patients that will develop PLE before they do that. And this is a patient presenting with plastic bronchitis. But the thing that we look for, you can see the patient obviously has the clear abnormality in the chest area, but what we look for is the duodenum, and you can see over here that the duodenum shows up, but it is not staining, and there's nothing leaking into that, and we've never seen a patient with PLE that has a normal looking duodenum like that. So this tells us that there is not failure of lymph system in the abdomen right now. Everything is in the chest, and we're probably safer to do an intervention, even if we have to shut down the thoracic duct completely. To do interventions, you have to get into the duct, and there's several ways to do this. This is the traditional way. This is transabdominal thoracic duct access. You just take a long needle, put some contrast. This is oil, which you can use in Fontanes. You just have to be careful. You can't really use in Glenn patients. And you put a wire into the thoracic duct, and then you thread a catheter. If you're going to shut down the duct, and this is what's called thoracic duct embolization, there's a microcatheter, there's a coil deployed, and then we inject glue. We now almost exclusively use histocryl. There's this other glue that you can use, but this is basically super glue, about 1 cc of super glue, diluted 1 to 3 with Lapidol. As I said, thoracic duct embolization, we really reserve it for cases where we have no other choice, because these patients of ours, especially the ones with heart failure or single ventricle physiology, they're going to need their duct. And with new interventions that are coming up right now that allow us to use the duct for decompression later on when they develop bad things like ascites, we really should do everything possible to preserve the duct, and we're working on developing newer and newer techniques that allow us to do this in almost all cases. And this is an example of that. This is a patient with a severe lung problem. He had chylothorax and plastic bronchitis. And all this was coming from a single large duct that was supplying the entire pulmonary perfusion. And you can see over here that we have a catheter inside this duct. We're occluding the duct. This is actually a 2-catheter technique that we use, because there's another microcatheter over here that we're using to push the glue forward. And that works really well, because you can see over here after the procedure, this duct is occluded. The thoracic duct that is going both to the right and to the left is connected to the veins on both sides, is open. And so we preserve central lymphatic flow. And now this patient, if develop problems later, we have solutions for them. For patients with chylothorax, we published this already. The outcomes are really, really good. I'm not talking about this group, which I'll show you later on. There's new things for them. This is multi-compartment failure. But for patients with this pulmonary perfusion or traumatic leaks, which is really rare, most patients don't have that. In almost 100% of the cases, we can get the chylothorax to go away with sometimes very selective embolization procedure. Same thing for plastic bronchitis. The outcome for those patients are usually pretty good. This is what they look like as far as casting before. This is our data for 70-something patients, what it looks like for casting after. This is some of the patients that have had residual casting. And there are new things that we've done now, especially with the invention of the intrahepatic imaging and intramesenteric imaging, that have allowed us now to define what is the problem in these patients and the reason why we maybe sometimes can't completely annihilate the casting. And I think even for these patients, we should be able to get to a point that in almost 100% or close to 100% of the patients, we should be able to control passive bronchitis. And this is an entity that we've now treated probably close to 20 patients with that had imaging, and we found that there was nothing wrong with the central lymph system, but they were having severe passive bronchitis with cholothorax, and these are connections from the liver, bypassing the central system and connecting directly either to the airway or to the pleural surface. And so they can do this. This is an example of that. So you can see intranodal lymphangiography showing an absolutely normal looking thoracic duct, and you can even see it draining over here. If you see this, then you don't ever try to embolize the duct or even touch it. There's no reason to do that. There's nothing wrong with it. And in this patient had this typical finding of this channel that was coming directly from the liver, going posterior, and then connecting directly to the peribronchial lymphatics on the left side. And when we embolized this channel, passive bronchitis completely disappeared. So these are these liver to lung connections. There's more about this that we will, again, discover in the future. Liver, as I said, extraordinarily important, and there's two entities that the liver really plays a central role in. PLE is one of them, and ascites, which is something that we are now more and more discovering. And again, mesenteric imaging is extremely important for that in addition to liver imaging. We won't go too much into the ascites today, but the PLE will just show a little bit about it. PLE, we know, is a lymphatic problem. Liver imaging is the key imaging for these patients. Intranodal imaging is not going to show you the abnormality in most cases, so really is not the way to do this. So all patients with PLE in our institution at least now get intrahepatic imaging as the mainstay for imaging. They will get intranodal to see if there's other abnormalities, and in all these patients now we also do intramesenteric imaging, because we've now found that there's circuits connecting directly from the mesentery into this. You can see over here, this is liver injection, and you can see the duodenum filling and then reflux into the stomach. And later on, you can see that this stuff, the contrast refluxes into the esophagus, and actually the MRI contrast will come out of the mouth. And you can see it lighting up the entire intestine. So this is quite severe PLE. If you look at this from the inside, so we do endoscopy in all these patients, these are these lymphatic streams. There are holes in the duodenal wall. These are what these lymphatic streams look like. We use this to guide our therapies these days. And if you inject blue dye into the liver, you will see that it will come out through these streams. Very nicely looking. This clearly is protein losing enteropathy. You can see some of the lymphangiectasia over here also. There's ways to intervene on this. These are these kind of embolizations that we do. We used to do them exclusively in the liver. Now we no longer do that. The liver embolizations don't work as well. We more do very targeted embolizations where they're much closer to the duodenum. And you can see when we're injecting the lymphatic channels, you can see the dots. These are glue that is coming out of one of those holes that you saw. And we know that it's in the duodenum because if we flush through our endoscopy catheter, you can see the C-loop of the duodenum and the glue just flushing forward. We are working now on summarizing some of our results with these type of interventions, and we've gotten a much more sustainable improvement in albumin with this. There are patients, and we are seeing a larger cohort of them now with what we call multi-compartment lymphatic failure. So we know that all the passive bronchitis patients, about 15% of them, 15 to 20% of them will have concurrent PLE and passive bronchitis at the same time. So this entity of multi-compartment failure occurs in many of the patients that we see. And the way that we define it is just abnormality in more than one compartment. And you can see here T2 imaging in a patient that has that. This patient has everything wrong. So it has passive bronchitis, cholothorax, or lymphatic thorax, lymphatic ascites, and PLE. These patients are much more difficult to treat, but there are new things that we're doing now that allow us to do this. So if in the old days it was more geared towards embolization, now we don't do that anymore for these kind of patients. And one most important thing is if you have a baby that has this, what we call congenital lymphatic flow disorder. So babies who are anosarchic, have ascites or cholothorax or more than one compartment problem, whatever you do, don't ever try to shut down their duct. Don't do pleurodesis on them. It's not going to work. There's very selective procedures that we can do with these babies, and maybe some of them we can salvage. Right now, our rate of allowing these kids to to grow up is probably around 60 to 70%. There's still high mortality in them. In the older population, there's these new procedures initially introduced in the 60s by Whitty and her co-workers, and now the Hiraska procedure, which was adapted from that, which is decompressing the thoracic duct that allows treatment of multi-compartments, not just one compartment. And this is the surgical approach to that. So you just take the innominate vein, you plug it into the atrium. Obviously, you have to confirm that the thoracic duct outlet is patent, and now we have a minimal invasive way to do that. And you have to know what the hemodynamics are, because you want your atrial pressure to be lower. Jack Rome has developed now the techniques to do this minimally invasively, and we published the first 2 cases. This is an LSVC that we did, but we've now done this type of procedure in all anatomies. So there is no anatomy that we have not been able to turn down percutaneously. So you don't have to do surgery to do this anymore. And we're working on now publishing the entire cohort of all the different kind of anatomies and how you do this kind of very innovative and fascinating procedure. And this is what it looks like. This is a patient that came to us with severe plastic bronchitis, PLE, ascites, and some fluid in the chest also. We had to do lymphatic interventions. What we found that the turndowns work better if you seal the big leaks, and if you don't seal the big leaks, those will persist even if you turn them down. So they get a selective embolization, and we did 3 procedures in this patient just to stabilize him, different kinds, and then ultimately did a turn down on this patient using, he was the one with the LSVC connected, so we put a covered stent in there, and you can see now the innominate is connected to the atrium, and this patient recovered within a few weeks and went home and is doing fabulously well. So I'll end by just saying there's lymphatic flow disorders are everywhere. All of us who are on this call today need to know how to deal with this. Anybody who wants to learn is always welcome. We've had a larger group of patients right now because of COVID. You know, we've had a break, but I'm assuming that at some point COVID is going to go away, and everybody is going to be welcome back to come over here to learn how to do this imaging, how to set up lymphatic programs. I've helped set up lymphatic programs all across the United States and in Europe and around the world. So everybody's welcome. And imaging is key. New lymphatic treatments are now available. And as more of us work on this, there'll be much more available. And as long as we do that, there's always going to be hope. And I'll end by just saying thank you again for having me. And I'm done.
Thank you, Dr. Dori. It's a beautiful picture, incredible. Thank you a lot. The next speaker is Sophie Malekzadeh-Milani. Sophie is an interventional cardiologist. Sophie?
Yes.
Can you hear? Okay.
Yes.
Hi, Sophie. Is an interventional cardiologist working in Necker Hospital in Paris since 2012. She's the lead of pediatric and good catheterization laboratory in Necker Hospital and in Pompidou Hospital since 2017. Dr. Milani's area of expertise is transcatheter intervention from fetus to adult with congenital heart disease. She has contributed to around 50 publications and has organized the first European meeting on transcatheter PDA closure in preterm infants in 2019. The topic is transcatheter closure of PDA in premature neonates. Sophie, good afternoon.
Good afternoon. I would like to thank you all for having me on this wonderful meeting, and I will present some of the results of transcatheter closure in preemies. The only disclosure I have is that I'm running currently a prospective studies on preterm having transcatheter PDA closure, and I received a grant from RVOT. So if you look at the history of the PDA, what happened from the first description of a PDA back in 1882, until today, where we can close virtually all the PDAs, even in babies weighing 700 grams. Well, several things happened. Surgical techniques developed over time. Interventions developed also and started to develop in around 1970, and also neonatal medicine had a great development. If you look at the neonatal care, basically, if you start to resuscitate babies younger and with a lower birth weight, you will have more PDA. And the lower birth weight you have and the younger the baby is, the more likely he will have a significant PDA causing trouble soon after birth. There are currently 4 different strategies regarding the PDA, and there are still ongoing debates, and this is not the matter of this topic today. One of them is observation, and in some countries, nobody does anything about the PDA, like in Holland. There are other strategies. One of them is medical therapy, but the efficacy is not so good, with around 60 to 70% of closure after medical treatment. The medical treatment has some side effect and has some contraindication too. The third option is surgical ligation, but it has a lot of potential side effect, like vocal cord palsy, phrenic palsy, wound infection, post-ligation cardiac syndrome. So neonatologists are not very keen on sending their tiny babies to for surgical ligation. And the last technique is transcatheter PDA closure. If you have a large duct in a tiny baby, obviously you will have pulmonary congestion and failure to wean from the ventilation. You will have systemic hypoperfusion, leading to necrotizing enterocolitis, renal insufficiency, and cerebral hemorrhage. Neonatologists have defined what a significant PDA was for them. It's a PDA larger than 1.5 millimeter, with reversal of the diastolic flow in the brain, in the kidney, and in the gut, and with left heart volume overload, with a LA to aortic ratio above 1.5. If you look at what happened in PDA closure interventions, in the late 70s, the first transcatheter PDA closure was performed, but as it was said earlier by Lee Benson, the delivery sheets were very large and we could only treat very large patients. And with time going on, with new device and new technology, we were able back in early 2000 to treat small babies, or relatively small babies. And about 5 or 6 years ago, we started to treat really, really small babies with a former ADO2S, now called Piccolo, or the Medtronic MVP plug. It's thanks to the technique and thanks to the new device that we were able to close, that we are now able to close PDA in very small babies, but it's also thanks to a lot of you guys that were very brave in trying to set up a program. We can't talk about transcatheter PDA closure in preemies without talking about Neil Wilson, who was the first who did that, but also a few other people. Dr. Zahn, who has demonstrated that you can transfer the procedure into the NICU. Dr. Satanandanam, who has published a lot about the technique and has emphasized on the very specific type of the duct in premature babies. Indeed, the duct is a fetal F-type duct, which is a long tubular duct. And Patrice Morville, who's a French doctor, who has the particularity being a cardiologist, but also a neonatal doctor, and who very rapidly saw the interest of transcatheter closure of the PDA in his own patients. If you want to start a program on transcatheter closure in preemies, the interventionalist guy is the last one in the chain. You need to have an anesthesiologist who's going to put your baby to sleep. You need to have a well-trained cath lab team who can handle those very fragile patients. You obviously, and I guess I was wrong by starting by an anesthesiologist, you need a neonatologist who is going to refer you the patient, because if the neonatologist is not convinced this is a good technique, you will not have a baby and you cannot have a program like that. You also, I guess, need to tell your surgeon you're about to start a program like that, because sometimes you can be in trouble and it's good that your surgeon is on your side. You need a cardiologist, well-trained cardiologist who can do a proper echo guidance and echo measurement of the PDA. And you need an interventionalist who's going to close the duct. It's a challenging procedure from the start. Transportation of this baby is tricky. Intubation has to be done by neonatologist back into NICU. Ventilation can be a problem, and in my unit, I cannot use the ventilator of my cath lab. We need to have the ventilator of the baby, so the baby comes with his own ventilator. Unit access can be tricky too, and peripheral access, I mean, can be tricky, and you can't have temperature loss, otherwise the baby is going to be unstable and you won't be able to close a PDA. If you close a PDA in a baby below 2 kilos, the procedure is going to be very modified compared to what we usually do. You won't get any arterial access, otherwise you would have limb ischemia. You will use venous access, mostly guided by ultrasound. Minimize the use of anticoagulation to avoid cerebral bleeding. Minimize the use of intravenous contrast for the fragile kidneys, and radiation in this very specific, fragile and growing population. You avoid the need, the additional procedures. There is no need to do right heart catheterization to take any pressure. You just go there, you close the duct, and then you leave. The device is going to be implanted intraductal, so no disc outside the duct. If you have a disc in the aorta or in the PA, you will block either the aorta or the PA. There are several landmarks that are helpful when you do the procedure: the temperature probe, and as a landmark of the aortic isthmus, and the trachea landmark as a landmark of the PDA. And you need, I think this is the most important thing, a real-time transthoracic echographic imaging with a trained echocardiographist, because when pressure rises, he needs to be sure of what he's telling you, and this is very important. These are the images you like to have when you go to the cath lab. These are 2D still images. One of them is the length of the PDA, and on the other one, you see very accurately the diameter of the PDA. Sorry, this is a running picture of the PDA. The PDA is tubular, has to be purely left to right if you want to close the PDA. And you can see on these images the LPA and the aorta. This is the device that we currently use because it has FDA and CE approval. This is the Placer Piccolo occluder. You can see that you have a central disc and two outer discs that are a bit larger than the central disc. And as a rule of thumb, just to really simplify for the talk, I would add 1 millimeter to the smaller diameter of the PDA to choose my device. Like if the PDA measured 3 millimeter, we would choose a 4 millimeter device. And in premature baby, we always use the shortest device to avoid any aortic or LPA protrusion. You have two imaging modalities. One is the angiography. It's the hand injection performed from the aortic isthmus to delineate PDA in lateral projection, and you can see that nicely on this aortogram. It provides good morphology and accurate measurement, but be aware of spasm. If the echocardiographer tells you there you have a very large duct and then you end up with a small duct on the angio, you might have a spasm caused by the probe. And be aware of not using too much contrast when you do this angio. And you have the transthoracic echocardiography. And here you see very nicely the tubular, very long, purely left to right duct, as well as the RPA and the LPA. It gives you very accurate measurement of the PDA diameter. It may underestimate the length, although not so frequently. It will help you to place the device appropriately, avoiding protrusion to the aorta or in left the right artery and assess the respiration before it. Obviously, you can also assess function and function and infusion in a complex procedure. I would say that my procedures are echographic guided, and this is mainly the imaging that I'm using. You also, when you do this fragile baby, have the challenge to cross the tricuspid valve. There are 3 ways to cross the tricuspid valve. One is a very floppy catheter, and this is used by one of the team in America, followed by the woolly wire to navigate through the heart. The other technique is a balloon end hole catheter to cross the tricuspid valve, followed by exchange of guide wire and catheter to get to the PDA. And the last technique that I will present you today is the microcatheter to cross the tricuspid valve, followed by a 0.014 wire to cross the PDA. And here is a lateral view of a baby undergoing transcatheter closure. You can see that the microcatheter has been flow guided through the tricuspid valve. And then once the microcatheter is in the RV, 0.014 guide wire is advanced into the descending aorta. On this guide wire, the microcatheter is then advanced as well in the descending aorta. And on this microcatheter serving as a tutor or as a dilator, you can advance very smoothly the torque catheter, the delivery system of the device into the descending aorta. This is what you see on this angio, on this fluoroscopy, sorry. And this is the release of the device. You can see that it's echo guided with the echo probe on in front of the picture. Sorry for that. And you have 2 landmarks that can help you, the temperature probe that you see sitting in the esophagus and the device must sit anteriorly to the temperature probe, but also the trachea landmark is here, and the device has nicely on the trachea landmark if you want it to do good position. You want to have a picture during release or just after release. You see the device sitting nicely with no residual shunt. You see a patent LPA and a patent descending aorta, and then you're happy that you did a good job. You can also have a good view just of the aorta. Sorry, my computer is huge. Sorry about that. Can someone help? Grace, can you do something?
We have
Can you
some
run my stuff?
with the audio.
Yeah, you have to close your camera. Close your camera and start to talk.
Okay.
Close your video.
Okay, hold on. Oh, this is not working. I'm sorry. I'm really sorry, guys.
No problem. But the only thing is you have to close your video. Okay, try now.
No, I just got a message. My computer is too hot. Oh, okay. Sorry.
Yes.
Grace, can you run it from your computer?
Grace.
I guess so. I'll try. Just a second.
But the sound is better.
Yes, if you close your video, you can talk.
Okay. Is it your screen that we are seeing now, Grace? No, it's my screen, right?
Yes.
Okay. Is it okay if we do it like this?
Yes.
Okay, let me try again.
Yeah, no problem.
Okay, so here you see a nice LPA view with the device. I'm sorry, guys. And sometimes it can be tricky if you have a very, very sick baby on high frequency oscillation ventilation. But here on this echo picture, you can see that despite oscillation, you can get accurate picture on echo. This is the LPA and this is the descending aorta. So there is ongoing growing experience, and there is improved ventilation in premature infants after transcatheter PDA closure compared to surgery, and this has been proven by several prospective studies. In the patient undergoing transcatheter PDA closure, there is no post-ligation cardiac syndrome, which is something that really frightens neonatologists, because they always say after surgery, the babies are really unwell for a couple of hours or 24 hours. And this is not happening when you do transcatheter PDA closure. As Dr. Zahn has demonstrated, it is feasible in NICU and you avoid transportation. We and others have demonstrated that is feasible without contrast injection to avoid kidney injury. Obviously, there are complications that have been described that are still described. It's LPA stenosis, coarctation, and tricuspid regurgitation. But with growing experience, we start to know how to avoid these complications. And it is now feasible and has been very nicely described by Sian Santarandanam that we can close PDA in infants after 700 grams. In conclusion, I would say that all these studies have demonstrate feasibility, but not only feasibility, efficacy in this fragile population of preterm infants. There is a high rate of success, improvement in ventilation, no post-ligation cardiac syndrome. Complications remain an issue, but they can be decreased by good echocardiographic guidance, good knowledge of the device, and appropriate device selection. And the long-term of the evolution of this fragile baby, like neurological development and also cardiac evolution of these kids, will have to be analyzed in prospective registry. I will finish by thanking all the different teams working with us, the anesthetist, the surgeon, the neonatologist, and my cath lab team. Thank you very much.
Thank you, Sophie. It's a beautiful experience. It's a growing experience in the world, but the perspectives are good. Next speaker is Professor Qureshi. Everyone knows Professor Qureshi. Professor Qureshi, can you hear?
Yes, can you hear me?
Okay, yeah, yes, very well.
I'm trying to share my screen, but I need Sophie's to stop sharing.
Okay.
Okay. Professor Qureshi is a consultant, pediatric cardiologist, and professor of pediatric cardiology at Evelina London Children's Hospital, Guy's and St. Thomas Hospital Trust, London. His main interest is interventions in pediatric and adult congenital heart disease. He's involved in many international meetings around the world. The topic is a catheter-based closure of sinus venous ASD. Good afternoon.
Afternoon. Thank you very much, Giulia, and thank you to everybody for this invitation to talk about sinus venosus atrial septal defects, which are usually associated with partial anomalous pulmonary venous drainage. These are my disclosures, and really right at the outset, I want to acknowledge my colleague, Eric Rosenthal, who's led our program in the development and progression of sinus venosus defect closure. We, of course, helped by other team members from imaging side, as well as physicists, as well as physiologists and other interventional colleagues from the department. So I want to acknowledge them right at the beginning. Sinus venosus defect closure has really been reported. The very first report was back in 2013 by Dr. Hussein Abdullah from Iraq, from Baghdad, Iraq, who used a combination of stents and in some cases devices, ASD devices, to repair sinus venosus ASDs. In between 2011 and 2013, 4 patients in his unit underwent sinus venosus defect closure. Their ages ranged between 7 and 23 years. 2 of the patients had 8 ZIG covered CP stents. 1 patient had covered CP stent combined with an Occlutech ASD device, and one patient had 2 covered CP stents and an Amplatzer PFO closure device 6 months later. So Hussein Abdullah, we need to acknowledge. And then subsequently, Gaurav Garg reported on a 35-year-old patient in whom a 12 millimeter by 61 millimeter Advanta V12 covered stent was implanted. And Jennifer Franke from Frankfurt, in who a 65-year-old patient in whom a patch closure was carried out. And the other colleague who's done a vast amount of work now is Shiva Kumar from Chennai in India. So I'll go through a few steps. The first step is, of course, planning. And we use either MRI, but more recently, exclusively CT scanning in order to help us with the planning. We used to use 3D printed models and then simulate with them as to the feasibility. And you can see here some of the models under fluoroscopy where we put a dilator from the right upper pulmonary vein into the left atrium and into the left pulmonary vein, and a stent in the SVC, and looked at it under fluoroscopy, 3D rotational fluoroscopy, to see whether it was suitable or possible to carry out catheter repair of this defect. And then once we've done the planning, we work out what size, diameter, custom-made 10-zig covered Cheetham platinum stent and its appropriate bib balloons are required and ordered. More recently, one of our fellows, Fu Duong, has been using computer simulation for us. And with that, he can put in a stent and rotate the image around, play around with it, work out how much flaring is required, what length stent is required, and what the possibility is of compression of the anomalously draining right pulmonary vein. And that gives us a good idea of the feasibility. And so we've been doing this rather than developing, printing 3D models. Then the next step is actually doing the procedure. All procedures have been done under general anesthesia. Transesophageal echo assessment is carried out of a defect in the pulmonary veins. We access both the right internal jugular vein as well as the right femoral vein, or one of the femoral veins. And we initially used to use right femoral artery access in order to pass a catheter retrogradely from the aorta to the left ventricle, and then across the mitral valve into the left atrium, and then into the pulmonary vein. That catheter could be a multi-purpose or a cut pigtail, but more recently we carry out transseptal puncture. You see here catheter pass retrogradely, and more recently we carry out femoral venous transseptal puncture, and once the sheath is in the left atrium, maneuver that into the right upper pulmonary vein, and that speeds up the process. Once the access has been obtained, you see here a check SVC angiogram through the internal jugular vein sheath in both AP and lateral projection. And you can see a catheter in the right upper pulmonary vein and a sheath in the left atrium. And then we carry out balloon sizing or balloon interrogation of the SVC combined with SVC and pulmonary vein angiograms in order to see whether there's any threat to the pulmonary veins being compressed. That's done in a biplane. Again, we check it on AP and lateral, and you can see here with the balloon inflated, angiograms are being performed. 3D rotational angiography is performed as well, and you can see here there is one view there where it shows that with the balloon inflated, the right pulmonary vein is unobstructed. There are some cases initially in whom we thought they may not be suitable, and that was largely because the compliant sizing balloon was bulging into the defect and compressing on the pulmonary vein. And so more recently, and I'll come back to this, we use a non-compliant balloon for that. Or the alternative strategy is we, as shown here, we put an atlas type of balloon from the transseptal puncture into the right upper pulmonary vein, and that then prevents the covered stent from obstructing the anomalously draining pulmonary vein. And you can see the still pictures here. Then it's a matter of selecting the sheets and stents and balloons. We used to use check flow performer 16 to 18 French sheath, but now use a Gore dry seal sheath. Usually 20 French is adequate. Bib balloons of the appropriate diameter that we've worked out, and usually that's 2 to 4 millimeters larger than the SVC balloon interrogation diameter. Generally, we use a Tenzig custom-made covered CP stent of between 6 and 8 centimeters long. And more recently, they've been either 7 or 8 centimeters because we found that at bigger diameters, the 6 centimeter long stent shortens too much and then needs an overlapping stent. The upper end of the stent should really be positioned at the level of the azygos vein and at least 2 centimeters into the SVC. And the bottom end of the stent needs to be below the upper end of the septum. And that usually translates to at least 2 centimeters below the SVC right atrial junction. And you can see here some of the next step where the custom-made stent mounted on the balloon is passed through the dry seal sheath. Check angiograms are performed, both in AP and lateral projections. And you can see fairly good position of the top end of the stent here. At the top end, another assistant has to maintain gentle traction on the guide wire in order to stop the balloon and the stent assembly melting down when it comes to inflation. Once we're happy with the positioning, we then inflate the inner balloon that you can see here, the inner balloons being inflated. It's all done very slowly, and then the outer balloon is inflated. And really, we need to check on transesophageal echo the bottom end of the stent before that final full inflation, because any adjustment that needs to be made is made at this point. Transesophageal echo is essential, and you can see here the sinus venosus defect before the stent is implanted, and here you see the bottom end of the stent has captured or is opposed to the fairly rigid or stiff part of the septum, and then some still pictures showing patent right pulmonary vein, and no residual shunt is seen here. And on this bottom left picture, you'll see the point I was making about the stent here overlapping the septum here. Then you know that when the stent is fully inflated, the stent will capture or catch on to the septum without bouncing across the defect into the left atrium. There are some cases in whom there's a significant residual shunt at the normal inflation, and so the bottom end of the Tenzig covered CP stent needs to be flared. And so we use a coda balloon at the bottom end in order to carry out flaring, which is guided by transesophageal echo. And so you can see here how the flaring is carried out. You have to be careful because over-flaring may result in the covering slipping off the bottom end by a few millimeters, which could then potentially leave a residual shunt. And if that happens, a second stent may be required at the bottom end. And also, if it shortens the stent too much, then a second stent may be required at the top end, and that generally tends to be a bare CP stent. So you can see here another stent coming along for implantation. The second overlapping stent can be implanted both from below or from the internal jugular vein approach, and you can see here a reasonable overlap, which then captures or secures or anchors the top end of the stent and prevents it from embolization. Our experience we started this in March 2016, 48 patients were considered, all of whom, and I emphasize this, all of whom have been adults. Of these, 29 patients have had successful catheter repair of the sinus venosus defect. 8 have been considered unsuitable, and the others are waiting for the procedure. In fact, since March of this year, because of COVID, we've not done any more. Age range between 24 and 66 years. Bilateral SVCs were present in 8 patients, and these patients tended to have a smaller SVC on the right, and therefore smaller diameter stents were implanted. Some information about cubic QS variation, access by retrograde arterial approach in the first 10 patients, and The remaining patients have had transeptal approach. There were 2 patients who had a PFO, therefore we used that. Covered CP stents, 5 centimeter long in 1 patient, 6 centimeter in majority, but more recently, we've gone towards 7 centimeter and 8 centimeter length CP stents. The right upper pulmonary vein, we've protected that because of a possible compression possibility with an Atlas balloon in 4 patients. And the diameters of the stent when it was fully inflated was between 18 and 30 millimeters. A second bare stent for anchoring purposes was required in 9 patients, and a second covered CP stent at the bottom end in 4 patients. And there was 1 additional PFO or ASD closed with an Occlutech device, and this was a patient who was a diaper. One of the exclusions initially was, as I mentioned before, this possibility of balloon bulging into the pulmonary vein confluence and obstructing it, whereas now we tend to either protect, as you see here, with an Atlas balloon, or we use a compliant balloon for interrogation. You see here an Atlas balloon in the pulmonary vein and a non-compliant balloon being inflated for assessment, and then eventually during the stent implantation, we've got an Atlas balloon in place whilst the inner and outer balloons are inflated, and there's the final picture showing good flow in the pulmonary vein. So just a few results before I finish. Residual shunt was present immediately afterwards in 11 out of the 29 patients, 38% on angiography, and in 15 patients on color Doppler. By next day, only 6 patients had a residual shunt on color Doppler, and then that gradually disappeared during the follow-up. There were a few complications, serious ones in 2 patients, one of whom developed a hemopericardium needing surgical drainage 3 days later, and we really couldn't find any other reason for it, being related to the transeptal puncture. And then 1 stent embolized 6 hours after the procedure. And in retrospect, this patient should have had an anchoring stent at the top end to stop it from moving, because we had not in the SVC. Other complications included femoral artery pseudoaneurysm in 1 patient and arm neuropraxia in 1, and a fibrillation requiring DC cardioversion in 1. And during follow-up of 3 months to 4 years, you see here, right, MRI remodeling has occurred in the majority of patients with a reduction in the end diastolic volume. CT scans have been in 22 patients, usually around months or after. MRI scans in 14 of the 17 patients, all showing good results. On the CT scan, the pulmonary veins have remained patent. There have been no late complications, and very importantly, at 24-hour Holter monitoring, there has been no evidence of sinus node dysfunction. Here's an example of a CT scan of different views showing good patency of the right upper pulmonary vein. So to conclude, catheter closure of sinus venosus ASDs is possible in carefully selected patients, and in our experience, it's been 75% of patients up to now, and other anatomies preclude it. It avoids surgery-related morbidity from stenotomy and bypass. It avoids risks of SVC stenosis or residual shunts and sinus node disease. Stent migration is a concern, and therefore we have to be very careful in the judgment about anchoring stents or using longer stents, and that may well reduce that possibility. I'll stop there. Thank you very much.
Thank you. Thank you very much. It's amazing experience. Thank you. And now we have Mario Carminati. Mario, can you hear?
Yes.
Okay, Mario.
Okay.
Mario is our friend. He's a director of pediatric and adult congenital cardiology at Policlinico San Donato in Milano. His main professional expertise is represented by transcatheter interventions for congenital heart disease in children and adults. He's authors and co-authors of more than 200 papers, several books, chapters, and took part as invited faculty to many international meetings. He was president of the Italian Society of Pediatric Cardiology from 1998 to 2001. He received the PICS Award in 2009. Is the president of Milano IPZ, a co-director of Frankfurt Congenital Structural Interventions meeting since 2000. He's an honorary member of a Romanian Society of Cardiology and the Spanish Society of Pediatric Cardiology. Mario, good afternoon.
Okay, thank you very much, Giulia. Hello to everybody. It's a great pleasure for me to be part of this outstanding faculty in this very, very exciting meeting. All the lectures were outstanding so far, and I had the pleasure to share with you our experience in using advanced modeling technique for helping us to improve and to optimize interventions in some structural, congenital, complex interventions. Well, just to very briefly to show how to do that, we get started from the CT scan in the patients, and from DICOM segmentation, we can achieve 3D models that can use on 3D computational simulation with the help of our bioengineers. And in some cases, you can do also a 3D printed model. Well, we've been using these techniques particularly for complex percutaneous pulmonary valve implantation, but also in some other complex cases, for example, some complex aortic obstruction. But I will be focused just on the 3D modeling on percutaneous pulmonary valve implantation. This is an example of the CT scan from which we can obtain the 3D STL models, as you see in this picture. And then you can see here the simulation, the computational simulation of CP stent expansion in a conduit. You can appreciate the modification of the size of the conduit and movement of the calcifications present in this particular case. Of course, there is a very complex bioengineer complex background to be able to produce these pictures that are actually close to reality, can simulate very, very closely what is going to happen exactly in the real tissues. Not 100% reliability, actually, but very, very close to that. And this is another example of interaction between the stent and the tissue as constructed by bioengineer work. And here we go in a patient where we can appreciate simultaneously the computational and the 3D printed model simulation or balloon inflation in a conduit. The 3D model, the 3D printed model is made of R-Flex material, which is a flexible material produced by Materialize or Mimics, and you may appreciate the balloon inflated across the right ventricular outflow tract, and the white spot that you see here are represented the calcifications of the conduit. And this is the real patient, the RV angiogram in the lateral projection, and then the picture of the same patient with pre-stenting and melody implantation. And as you can see, the real angiographic pictures are very, very similar to the 3D printed model that we simulated the day before, implanted the same stent, the same length, and the same size. And the two pictures are very, very close to one to other. This is another example of a different right ventricular outflow tract dysfunction. It's a severe pulmonary regurgitation in the tetralogy patient after transannular patch repair. And in this particular case, we had a funny origin and course of the two branches, some kind of crossing pulmonary branches, and the very dilated main pulmonary artery. So we asked ourselves how to implant a valve there. And before that, how to build an adequate landing zone for that. So we went ahead with a 3D printed model that you see here. And this case was reported recently in International Journal of Cardiology. And we tried to figure out many ways to construct a stent implantation in the main PA to build an adequate landing zone. And the best we achieved was to implant a stent in right pulmonary artery, joining the origin on the left. And afterwards, we thought that another stent could have been implanted in a main PA, which is very, very dilated. And we did that exactly. And you see the right pulmonary artery and main pulmonary artery pre-stenting with two telescopic stents, as we did in the printed model and seen in fluoroscopy, and the same picture in the cath lab in the same patient. And we replicate exactly what we did in the printed model. We're happy because eventually it was very, very easy at the end to put a Sapien in this pre-constructed landing zone that was very, very adequate at the end with excellent immediate result. This is another patient, another tetralogy patient with severe pulmonary regurgitation after transcatheter patch repair or infundibular patch repair. But as you may see here, there is a restriction point, more or less at the level of the annulus. So we thought that in this particular case, because our trend is to do that, we asked ourselves whether it's going to be possible to implant directly a Sapien valve in the pulmonary artery without restenting. And we inflated the balloon there just to make sure that we occluded completely. And we simulate the expansion of the stent holding a Sapien 329 in place. And as you see here, the position of the stented valve looks very, very nice in the 3D printed model. And now you see the valve exactly in the position we wanted to be. And you see in the unfast view, the valve and the stent in the annular position on the pulmonary valve. So that was the idea, to put the Sapien valve in the patient. And this is exactly we did in this patient. This is the real angiogram on the patient. And that's the Sapien 29 implanted directly with the help of a long dry seal sheet. And you see the exact position of the stented valve as you simulated the day before in the 3D printed model. However, we were even more interested in working with our bioengineers to use the fine elements analysis process to simulate the PPVI, and particularly to look for the possibility of predict the stenting, the possible stenting related adverse events through this technique of patient-specific finite elements modeling. And we were particularly interested in verify whether it's going to be possible to predict a potentially lethal complication that you all are aware of, represented by the coronary compression. And this is an example of the severe right ventricle to pulmonary artery conduit obstruction, conventional angiography. We did a simulation with finite element analysis after having checked that the coronaries were normal, as you see obviously in this angiogram. And this is the simulation. You see when inflating a balloon with this finite elements analysis, the balloon will expand the conduit and is going to compress the left coronary. So obviously we wanted to verify whether this simulation was real, and this is the real patient with the balloon inflating the outflow tract. And as you see very, very clearly, the compression of the LAD was confirmed completely. This is another patient with dysfunctioning calcified conduit, and we tested with the finite elements analysis the possibility of coronary compression. And with the simulation of inflation of a 17-millimeter balloon, the coronary, the left coronary, was far enough not to be compressed. And this is exactly what they found in this selective left coronary angiogram with the inflated the balloon up to 17 millimeters. But what about to go ahead and inflate more the balloon to 22 millimeters? Here in the simulation, there was a compression, and again, the same compression was confirmed exactly in the angiography shown in this balloon inflated and simultaneous left coronary angiogram. So we were very happy that with this simulation performed in 13 patients, in 3 patients, we could predict correctly the compression of the coronaries, and in all 3 patients, the compression of the LAD was confirmed in the cath lab. So in conclusion, computational simulation and in some selected cases printed model appears to be extremely helpful for planning transcatheter complex intervention. And I'm very grateful to my team and also to my friends in bioengineers working in the Polytechnic in Milano that we started work together some years ago, and we keep going like that with great satisfaction. Thank you very much.
Thank you, Mario. It's a beautiful talk. Great. It's a beautiful team. So we can start, if you want, the discussion. Sasha, Ivan, Zahn.
Yes, we have prepared some poll. The first one is, we can start with Dr. Carminati. So here is the poll. Dr. Carminati, can you please read the poll for the people?
Yeah, well, the question is, 3D printed model can be obtained by using preferentially this imaging tool, 3D echo, MRI, or CT.
So people are answering very fast. I think that the most frequent answer is CT scan, but I will ask you. We reach at least the 50% of people who is answering, and then I will share with all of you.
Yeah.
Here we go. These are results.
Well, that's quite correct. I mean, the best tool is the CT, in spite of the fact that we can also achieve the results from MRI and less commonly for 3D echo, but CT is certainly the best way to use it. Yeah.
We go fast with a second poll from Dr. Carminati, and here we go.
Okay, the finite elements analysis prior pulmonary valve replacement can predict coronary compression. Most of the times, never, or only in cases with pure pulmonary regurgitation.
Again, the answer A is the most favorite from the audience.
I'm happy about that because it means that I show significant and pictures that convincing people that with this computational technique, we are able to predict this coronary compression. I'm very happy about that.
Yes, it was amazing. And now we go to Dr. Yoav Dori. He asks, there is a poll for Yoav. Are you still there?
Yes, I'm here.
Yes, can you Please read the question to the people, please.
Sure. So what is the treatment of choice or lymphatic treatment of choice for patients with multi-compartment lymphatic failure? So one is thoracic duct embolization, 2 thoracic duct ligation, 3 pleurodesis, and 4 selective lymphatic duct embolization.
I think I'm sure that you will love this answer, and here is.
Good. Excellent. 72% are correct. So in patient with multi-compartment failure, at all costs, preserve the thoracic duct, especially with the option of decompressing it. So we can use it for those kind of procedures. So almost never, ever close it down.
Okay. Thank you. So now we can, Ivan, we can go ahead. We have, thank you very much. The experience from Affinity Elements, I think, is a very big impact in clinical practice for patients with tetralogy of Fallot.
Yes, I want to, okay, Sasha?
Yes.
I want to thank all the speakers. Those were phenomenally good talks. Too bad we couldn't hear the applause from the 600 or so people listening. I'd also like to ask the speakers coming up, if we don't mind, if we could make up a little time. We're running pretty behind, and I know people have to go and actually go to their jobs. It gives me great pleasure to introduce the moderator for the next session, who actually needs really no introduction. Everybody knows who Ziyad Hijazi is. Professor Hijazi is a professor of pediatrics and medicine at the Weill Cornell Medical School. He's also the chief acting medical officer and executive chair of the Department of Pediatrics at the Sidra Heart Center in Qatar, in Doha, Qatar. He's the medical director, International Affairs Office, editor-in-chief, Journal of Structural Heart Disease, also an honorary professor at the University of Jordan, and perhaps most important to many of us, has been the president and real founder of the PICS Foundation and meeting. Ziyad's going to lead us for the second session, which will deal with transcatheter pulmonary valves. Ziyad?
Thanks, Evan. Thank you, everyone, and good afternoon, good morning, good evening. I would like to make a slight change in the schedule, but before that, I want to thank the Congenital Heart Disease Academy, Grace and Sasha here for putting this great symposium together. Slight change because Dr. Gillespie, as usual, he has to run into an emergency. So Matt, the professor of pediatrics at the University of Pennsylvania, and he's the director of the cath lab at CHOP. He will start the first talk, and then we will go from there. Matt.
Okay, thanks, Z. Sorry for, let me see here, hold on, here we go. All right, do you see my slides there?
Not yet.
Hold on. Let's see.
Yes.
Now we see it, Matt.
Good.
Great. Let's see this here. Do that. Give me 1 second. All right, great. Now you can see them?
Perfect.
So sorry, thank you to the organizers. Thank you to Z for the opportunity to talk to you about the Harmony valve. Sorry, my video camera's not working. For those of you who don't know what I look like, just picture a young Hercules. That's pretty accurate depiction of what I look like. All right, this is an update on the Harmony valve. Here are my disclosures. So the Harmony transcatheter pulmonary valve is one of a handful of devices we're going to be talking about today, and it's one of the original self-expanding platforms that we're now coming online to treat patients with pulmonary regurgitation, and it's really a really exciting time to be an congenital interventional cardiologist. On the left-hand side here, you see the original Harmony valve, which is the TPV-22. It's an AOA-treated porcine pericardial valve that has 6 nitinol zigs that are held together over a knitted polyester cloth. And on the right was the second generation device that was brought in as part of the iteration process on the Harmony platform. It's called the Clinical 25 device, which was shorter in length and wider at the inflow. And we'll talk about how we came to that design in a second. And then that evolved into what's called the Modified 25 device, which had all the benefits of the clinical 25 device, but was much easier to deploy, much predictable in terms of deployment, which is important, which I'll talk about in a second. So this is a little animation showing you how the Harmony valve actually works. That's a modified 25 device animation. This is how you load it, which is what I wanted to show the animation for. There's a loading funnel that goes over the outer sheath, and at the proximal end of the Harmony zigs, there's 9 zigs, each with a little suture loop on it. They're gathered in centrally by a coil mechanism simply by spinning the device. And then there's a little clamshell extension that goes on to the funnel, which you'll see here, and screws into the funnel that's over the outer catheter, and just very easily, it gradually reduces it down so you can pull the device and reduce it down to size into the outer catheter. You marry the nose cone to the outer catheter, and just in standard catheter techniques, you run the device up over a stiff guide wire into your target location. We typically do it this way, where we launch the carrot, which gives us some stability in the LPA, and then it's just a matter of uncovering the device in a gradual stepwise process and let the self-expanding properties of the frame take over to anchor it in the position within the pulmonary artery that you planned. So this is how this procedure goes, and we'll show an example of a real case in a little bit. So there you have it there, and then to release it, you just turn the little turning mechanism, and each of the sutures comes off and the bottom zig blossoms into position there. And voila, you have a replaced pulmonary valve. Much better than surgery. Okay, so where do we stand so far? Well, the Harmony device is still in the trial phase in the United States. It started in 2013 with the early feasibility trial involving TPV-22. There were a total of 20 patients in that trial, and you can read the results. The bottom line is that it works, and it worked well. And based on the strength of this early feasibility trial, which is the first early feasibility trial performed in the United States, based on the results of that, we moved into pivotal trial in 2015. Now, the pivotal trial involved the TPV-22, the clinical 25, and what has evolved to the modified 25, the MTPV-25 on the bottom right-hand part of your screen. And we're now in the continued access phase, and to date, there have been, as of Tuesday, there have been 76 Harmony implants at multiple sites in the United States. What are the results so far? So Lee Benson presented and published the 3-year results from the early feasibility trial, which involved TPV-22. So you can read about that. The results were actually very good. And John Cheatham just presented the 6-month pivotal data, which involved use of the 22, the clinical 25, and the TPV-25. Briefly, if you look at safety, which was the primary outcome, it was safe. There was no device or procedure-related mortality, and that's important. Okay, you don't want a device that's going to lead to mortality. So we were very good in that regard. Freedom from device failure hit the threshold that we needed that we set for ourselves, but it's at 84%. 7 of those were in the clinical 25 device, and we'll talk about that in a second. And then freedom from valve dysfunction was at 89% based on the definition on the left-hand part of your screen there. And again, that was the clinical 25 device. So there were 3 catheter reinterventions and 2 surgical explants that you can read about there, and all 5 of them were with the clinical 25 device. So it's important to understand that nobody's ever going to have to wrestle with the clinical 25 device. Where this device came from was the TPV-22, the original Harmony valve, had a very high screen failure rate as we were starting into the process back in 2013. So based on those screen failures, we designed a device to be this size, the size and shape. Sorry, I don't know why it's going forward. This size and shape that the clinical 25 was, but some modifications to the frame made it difficult to deploy in a predictable way. And that's why some of these catheter reinterventions, reoperations have happened. Fortunately, through the iterative process, we learned from this, and we now have the modified 25, and we'll show an example of that in a second. If you look at the results, there's no obstruction, there's no regurgitation of significance at the 6-month follow-up in the pivotal trial, and very trivial to mild perivalvular leak. this is what our planning process looks like, very similar to what Mario just presented. It's based on a gated CT scan. And what you're looking at is the dynamic nature of the RVOT, which we'll talk about through the rest of these procedures. The RVOT is a very difficult place to implant into because it elongates in systole and gets big at the PA bifurcation in systole and small at the annulus in systole and the inverse in diastole. So it's a very dynamic environment. It's a very challenging place to implant a self-expanding device into. What we do is use the gated CT to do all the virtual modeling, some of which Mario showed, up to and including implants of a frame into an SLA model, as you see here. And then based on this, every patient gets what we call the report card, which involves the virtual models, the SLA models on the right, and importantly, the perimeter plot, which we're showing here. So the perimeter plot was really created by an engineer at Medtronic at the time named Brian McHenry, and it really became the tool we relied on and to this day for the trial are relying on. And this is what it looks like. So the distal MPA is at the top, the proximal MPA is at the bottom. The anatomy and systole is represented by the red line, the anatomy and diastole along the RV outflow tract and MPA is in the blue line. The completely expanded frame is the black line, and the gray is the minimum interference criteria that we think we need for a secure implant. So it takes a little bit of time to get used to these things, but if you have significant overlap in the green zones there, you can predict that the device is going to stay in place where you implant it. So on the left is an acceptable fit, on the right is an unacceptable fit. As you can see, the green is way off in diastole and systole. But what these perimeter plot tools allowed us to do is we would screen fail and then build a device based on our screen failures to match all those anatomies. And that was part of the iterative process of the early feasibility study that led into pivotal trial that led us to the 3 devices that we have now. So every patient goes through this. Here's an example I'll just go through quickly. This is this patient's perimeter plot for TPB22. You can see that it's floating around in the lumen. It has no contact with the blue nor the purple line there. So you would not, it would be undersized. This is what the perimeter plots have graduated into. They're much slicker in appearance thanks to Mustafa Tului at Medtronic and Megan Anderson. And you can see that they can give us a very precise assessment of what the outflow tract looks like in systole and diastole, and then actually tell us where we should aim for the top of the device. So if you sit that 9.1 millimeter is the landing zone, if you sit the device there, you can get it, you're going to get a secure anchoring proximally and distally. Here's a baseline angiogram in the main pulmonary artery. You can see it lines up with our model pretty nicely. The delivery system advances very easily. You know, you can use a 26 dry seal device, which we have been doing lately just because it facilitates easy transfer and can be there as a bailout if you need it. We take a sighting injection pre-deployment, and then it's just a matter of, just like in the animation, opening the frame slowly and then releasing Zig-6 by turning the screw on the bottom. So then in the end, what you have is a competent pulmonary valve that's in secure position. Here's an RV-gram here. You can see it's reasonably sealed both proximally and distally, and this is what the echo looks like the next day. So no significant pulmonary regurgitation, secure device implant, unobstructed branch pulmonary arteries. So, and just like we predicted, there's our model there. This is where we intended to implant it, and I think if you look at how these played, it played out exactly as we wanted it to go. So in summary, you know, the Medtronic Harmony platform really came down a very unique development pathway, starting with the early feasibility trial, which led to iteration of the device through device sizes to get us to the 3 that we have. There were 3 devices used in the initial phase of the trial, and I think the top and bottom here will make it into commercialization. The 3-year data from the early feasibility study, which is published, and the 6-month pivotal data are very promising, and we have publications coming. At this point, we're anticipating an FDA submission later this fall, and hopefully sometime first, second quarter, COVID permitting, we'll have approval for commercial use in the United States in early 2021. I'd like to acknowledge Medtronic, and the FDA, guys, has been fantastic through this process. This early feasibility pathway is really a game changer for our patients. I got to acknowledge John, because John, through this whole early feasibility and pivotal process, has really been an incredible steward and incredible generous with his time steering the project, and as well as all of my co-investigators elsewhere. I'll stop with that. I'll stop, and thank you very much. Throw it to you, Z.
Thanks, Matt. Thank you. Great presentation. I know that you have to run to the cath lab, so I don't know whether we can take any question now or maybe leave it to the end. Hopefully you'll finish before we end the trial.
Yeah, you can, and if not, Z, John can answer all these questions as well, right, John?
Good luck in the case.
All right.
Good luck.
Hey, great session, guys. Thank you.
Thank you. Evan, I'm going to go next, I assume, right?
Yes, Z, that's perfect.
Okay, so let me share my slides here. Share. Do you see my slides, guys?
Yes, we do.
Yes.
Just have to go to presentation mode.
Yes, yes. Are we okay?
Yes.
All right. So this is my disclosure slide. I'm consultant, to two companies in the valve area, Colibri Heart Valve and Venus Medtech, that makes the valve. So let's talk about pulmonary valve replacement and start with the indications for that, because I did not realize that there were no talks about the indications. As you all know, that there was a paper published last year, which was an update to the 2008 guidelines. So now we go with the 2019 guideline, which were published in Circulation and JACC and other journals. And as you can see this slide here, basically the majority of patients with native RVOT tract are patients who underwent transannular patch repair. And then we look at their left ventricle, whether they have decreased systolic function, yes or no. If they have no decreased function, you look at the pulmonary regurgitation severity, and then you can assess all of that. So the bottom line, with MRI, you need to look at the right ventricle end diastolic volume index to be more than or equal 160 ml, or in systolic volume more than 80 ml, indexed, and of course the regurgitant fraction. Of course, if they have symptoms, then we don't have to necessarily stick with such criteria. And again, also some of the patients, they may have some tachyarrhythmias. If they have tachyarrhythmias or residual lesions, of course, we have to consider taking them to the cath lab and do pulmonary valve replacement. What are the currently approved valves for conduits? We know them, the Melody valve as well as the Edwards-Sapien valve. Those cater to approximately 25 to maybe 30% of the patients needing valves. On the right-hand side of the slide here, you see those patients who require basically a conduit between the right ventricle and the pulmonary artery. On the left-hand side of the slide is the majority of the patients who underwent what we call the transannular patch repair, where they have significant pulmonary insufficiency. And the valves that are designed specifically for this are a few of them. You already heard about the Harmony valve, as Matt discussed it, then the Venus P valve, and then of course the Pulsar valve, which you will hear later on, and the PT valve that John Cheatham will discuss, and of course other technologies that Dr. Evan Zahn will talk about. Let's talk about the Venus P valve. It's made of nitinol, self-expandable, multi-level supportive frame, and the leaflets are made of porcine pericardium. The entire valve is covered except the distal, as you can see on the slide here, the distal cells are not covered, and that's where you will anchor the valve at the bifurcation near the LPA and RPA origin, so that you will be able to access the branches if the valve is deployed way distal. And that's where we would like to deploy the valve as distal as possible, so that it will be anchored there. And the proximal part of the valve is flared up as well, and it is covered. So when we talk about diameter of the valve, it's the tubular part of the valve in the middle right there. And it's available in sizes from 16 to 36 millimeter. And the length, we also talk about the length of the tubular part, and it's available from 20 millimeter to 30 millimeter. And the distal part is 10 millimeter longer, and the proximal part 10. So a 20 millimeter long valve, it's basically 40 millimeter, the entire valve. This is the first paper actually we published on the first in human cases in 2013. So now we have actually just over 7 years of experience from the first 2 patients who are still doing well and alive. This is a lady, the first patient in the world to undergo the venous P-valve. You can see the angiogram there, the severe PR. You will see the lateral now. There's the lateral angiogram, severe pulmonary insufficiency. And then we do similar to what would you do in the Sapien and the Edwards valve. Balloon sizing, you need to assess the proximity of the coronary arteries as well. Similar to this injection here. As well, we occlude the RVOT tract and injection in the right ventricle at the same time to give us the size that you need. And then basically you choose the size of the valve and you go from there. So in the interest of time, I'm going to scroll here so that we can scroll here, scroll until the valve is deployed. Self-expandable valve, you can see it there, no pulmonary insufficiency at all. And then you do here in this case, an echocardiogram. This is an intracardiac echo showing that there's no pulmonary insufficiency at all. So it's really straightforward. So we did 2 major trials on the valve, the Chinese FDA trial, and the inclusion criteria are here. We were conservative in that one. We looked at patients, anybody who had indexed RV volume more than 130 ml, plus other criteria. And we did over 50 patients. The safety endpoints, occurrence of death or reoperation at 12 months. Performance, you need to look at success of placement and implantation of the P-valve, as well as improvement or abolition of the pulmonary regurgitation during the follow-up. And we looked at the size of the right ventricle by MRI at 6 months follow-up. These are the sites that participated in that, 55 patients in China. And you can see here the age average at 28 years, weight average 53 kilogram, majority were females, and the age at the first operation in China, as you know, they have operation at a later age than the Western world at 13 years of age. These are the sizes of the valves. You can see the majority, 18 patients, were the 32 diameter and 30 millimeter length, the tubular part. And then, of course, some patients 26, some patients 28, but we tried all valve sizes in these patients. The good news, no mortality at all. Then we had reoperation in 1 patient. Procedural success was 100% of the patients. The 1 patient mortality was traffic accident. So again, here is the outcome. Number of subjects catheterized, 55, attempted 55, number of subject success, 55, so the 100%. Short-term effectiveness in 41 of the patients. 2 subjects with unacceptable hemodynamics at 6 months, and 95% of the subjects with acceptable hemodynamics. Acceptable hemodynamic defined as mean RV tract gradient by echo less than 30 millimeter. Regurgitation, we know that the valve is very effective. As you can see, by default, all of them, they had severe insufficiency before, but at the 6 months follow-up, as you can see here, majority of the patients, no or trivial regurgitation. And if you look at their neo-COT classification, they all improved at the 12 months follow-up. If you look at the MRI data, as you can see here, before they had approximately 140 ml per meter square, and at the 6 months follow-up, significant reduction at 82 ml. So the valve does result in remodeling of the right ventricle. The second biggest trial, which is the CE trial, the PI of the trial was Dr. Qureshi from London, and many centers participated. The difference between the CE and the Chinese, we were a little bit more conservative with the CE, where we requested the right ventricle in diastolic volume to be at least 150 ml per meter square. The rest of the criteria were the same, safety and performance was as well as the same. 81 patients implanted, 1 not implanted, so total enrolled patients 80. These are the sites in Europe as well as in Doha, Brazil, and Taiwan. By MRI, you can see the number, the right ventricle in diastolic volume, mean of 159 ml, and at 6 months follow-up reduced to 116. The insystolic 85 reduced to 62. Again, you can look here, the regurgitant fraction before was at 45%, and of course at 6 months follow-up, significant reduction at 3%. Zero mortality at 30 days, and reoperation 0%. Success was at 100%. Now, the valve was also implanted in many different countries and around the globe on compassionate basis, and this is a list of many of the countries where the valve was implanted on compassionate basis. To conclude, the currently approved valves cover about 20, maybe if you stretch it to 30% of the patients. So this leaves large number of patients where the approved valves, they do not help these patients, and that's where the valves designed for native aortic tract become handy. The venous P valve is a promising, and the CE trial has been completed, and we are hoping to start a US trial sometime towards the end of this year or early next year because of the COVID pandemic. Thank you for your attention. So now we'll take the share the.
Great talk, Z. I think now we move on to Dr. Kim's talk about the Pulsed valve.
Yes, I need to unshare here with you. Stop sharing. Okay, go ahead. Do you want to introduce him, Evan?
Go ahead, Ziyad.
Okay, so let me introduce Dr. Kim. Dr. Kim is an associate professor at the Department of Pediatrics at Seoul National University Children's Hospital. He received MD and PhD at Seoul National University. His main interests are catheter intervention for congenital heart disease, cardiomyopathy, as well as pulmonary hypertension. Dr. Kim.
Can you see my slide?
Yes.
Oh, thank you. So thank you for having me a chance to introduce a Pulsed valve. Especially thanks to online committee. Most of the audience in this webinar may not hear of Pulsed valve, but since last year autumn, after current FDA approval, we had much progress nowadays. This is my disclosure. The first uniqueness of Pulsed valve of first-time pericardium. The remove the cell. And
Dr. Kim, excuse me. I think it would help your audio if you turn off the video of yourself because we're having a little trouble hearing.
Okay, okay. I'm sorry. I cannot find it.
It's at the bottom by where the mute button is, the bottom left. Yes, perfect.
Yeah, yeah. Okay.
Great.
It's okay?
Yes.
Okay, thank you. So we treated alpha-galactase to reduce immunogenicity and later calcification. Second uniqueness of Pulsed valve is woven texture of nitrile wire backbone. So you can see two woven texture of the two nitrile wire string. And treated porcine pericardium covered 25 millimeter height, and distal part is always less covered to identify where is distal part. Between these two radio-opaque markers, treated porcine pericardium is located. From the Pulsed valve profile, outer diameter ranges from 18 to 32 millimeter by 2 millimeter increase, and both ends are flared 4 millimeter larger than outer diameter. And total length is in the implanted human body was 33 or 38 millimeter until now. This is delivery system. Usual length is 110 centimeter. And at the head portion, we made 3 hook blocks for controlled deployment. At the handle portion, there are knob and slider for sequential deployment. Outer diameter of the delivery system is 18 French for up to 28 millimeter valve, and 20 French for 32 millimeter valve. Pulsed valve landing zone is main pulmonary artery, and we always try to implant the Pulsed valve in the just main PA according to the patient main PA shape. For Pulsed valve implantation, we are measuring proximal PA annulus diameter, distal diaphragm diameter, narrowest area and total length from proximal to distal, and using the multiple imaging modalities. We usually decide 1 or 2 millimeter larger valve than overall main PA diameter. In most cases, a total length of the main PA usually less than 40 millimeter. 33 or 38 millimeter pulsar valve is usually fit for the most native RVOT regions. You can see a well-seated pulsar valve in the just main PA with good valve function in one typical patient. The pulsar valve loading is quite simple. By using this crimping system, we can easily load the valve in several minutes. For support wire selection, you can use any branch pulmonary artery as you want according to the patient's shape, though both ways show different characteristics during procedures. And after flaring distal part and by rolling the knob clockwise, we can do repositioning during the RV angiography and deploy fully the valve by pulling the slider slowly. As you know, our native RVOT has a diverse main PA shape, so we should adjust a valve position according to each patient's main PA shape. The pulsar valve has some advantage to adjust the position to implant because of rather short total length, 33 or 38 millimeter. So for type 1 pyramidal shape, we can implant this valve in the deep bifurcation site carefully in selected patient, like in this patient. The type 2 straight type, straightforward, just implant in the middle of the main PA. Type 3 reverse pyramidal shape, very challenging cases, but carefully we implant valve if the landing zone is enough. Type 4 convex shape, implant pulsar valve at the distal bifurcation site or just into the pocket. And type 5 concave shape, the implant pulsar valve in the narrowest area if sizing balloon dilates this area enough. Now let's see specific challenging cases. The first case is a patient with LPA stent, of which proximal part of stent was protruded in the distal main PA. From the lateral view of the cine angiography, the PA annulus level about 25 millimeter, the wide stereo 30 millimeter, and total length from the RV outlet tray was 33 millimeter. So we carefully implanted the 28 millimeter diameter and 33 millimeter length pulsar valve carefully, and you can see well-seated pulsar valve at the PA annulus level with good valve function. This case was done in Argentina by Dr. Hannes Truja for 65-year-old TOF patient with RV failure. Because of high risk of surgical operation, we decided to implant pulsar valve after a CP stent implantation. So after carefully implant the CP cover stent 10G 45 millimeter with the BIB 26 millimeter 6-inch balloon catheter, we implant pulsar valve 28 millimeter diameter and 38 millimeter length, and you can see good valve function, and the pressure was very smooth. This 32-year-old short patient with severe kyphoscoliosis, and this patient was refused the surgical PVR at other hospital. So main PA angiography showed a very short main PA, about 20 millimeter. So we selected the 28 millimeter diameter and 33 millimeter length of pulsar valve in this patient. So after full deployment, you can see compactly seated pulsar valve from RV angiography with good valve function. So until now, for the Korean FDA approval study, we implanted 25 patients before 2019 May. After getting Korean FDA approval, we implanted 40 patients since last year, October. And for the compassionate use upload, we implanted 13 pulsar valve in Taiwan, Argentina, and Vietnam since last year, November. For C approval study, implanted 18 patients since last year, December, in Spain, Turkey, and in Korea. So until now, totally 96 patients was successfully implanted pulsar valve. From now on, let's briefly see the midterm result of 25 patients, Korean FDA approval study. The mean follow-up duration was 26 months, and there was no device-related serious adverse event, and stent fracture and infective endocarditis. Pulmonary regurgitation by echocardiography was stationary, and no aggravation of PR over time. And 6 months follow-up MRI showed significantly decreased RV end diastolic volume. And pulmonary stenosis measured by mean pressure gradient from echocardiography showed that there was no PS aggravation progression over time. So in conclusion, from the experience of pulsar valve implantation, pulsar valve may have this kind of merit. The multiple steps of specific tissue treatment, we anticipate longer durability of the valve tissue. Because of less bulky and less long valve profile, the pulsar valve is very user-friendly, so easy valve loading, good trackability into the main target area, and can be implanted in the patient with the branch-based stenosis with or without stent, short main PA, and or even in the triangular shape main PA. And because of knitted wire backbone stent, there was low risk of stent fracture, and we are using low profile delivery catheter. Thank you for your kind attention.
Thank you. Thank you, Dr. Kim.
Yeah.
Thanks so much. Evan, do you want to present Dr. Cheatham?
Sure. I've heard of that guy.
I did too.
Yeah. John Cheatham is a professor emeritus at the Department of Pediatrics and Cardiology at the Ohio State University College of Medicine and Interventional Cardiology in the Heart Center at Nationwide Children's. As everyone knows, John's area of expertise has been transcatheter intervention and hybrid therapy across the age spectrum for congenital heart disease patients. He's done pretty much everything there is to do in interventional cardiology, has published more than 200 peer-reviewed manuscripts, more than 30 book chapters, and speaks all around the world as much as anybody. John was selected as one of the top 25 innovators in healthcare by Health Imaging and IT, and has received the Career Achievement Award at the 2007 PICS conference. In 2015, John was named Master Fellow of the Society of Cardiovascular Angiography and Interventions, and in 2016, John was awarded the Career Contribution Award at Nationwide Children's Hospital. It's a pleasure to have John come and talk to us about the new and exciting PT valve coming out of China. John?
Thank you very much, Evan. I had Matt's talk up there in case I was going to give it. You can see the screen okay?
Yes.
Okay, very good. So I'm going to
go
go ahead.
We can't see you, Dr. John. If you could turn on your video.
No, Ziyad told me to turn it off so the sound is better.
Okay, yeah, this is true. This is true.
Okay. I'm just obeying Z's orders.
All right, John, thank you.
Okay, so again, we'll talk about the MedZenith PT valve. Disclosures, you can see my disclosures, consulting with a number of companies. So the background, and you've already heard 2 presentations from Asia. And one of the reasons, of course, is that in China alone, there are around 200,000 newborn babies born with congenital heart disease every year. That means about 76,000 open heart surgeries for congenital heart disease a year, which means about 15,000 operations for tetralogy of Fallot a year. And most of these patients, as you know, will have severe pulmonary regurgitation. So what you've already seen is the self-expandable frame housing a tissue pulmonary valve are ideal for this type of therapy in patients that have severe pulmonary regurgitation. Okay, let's go see why. There we go. The PT valve description, it's symmetric, which is different than the valves you've seen so far. It is covered with porcine pericardium. It's laser cut nitinol. There are 3 porcine pericardial valve leaflets with seal membranes. You can see that because it's symmetric, the proximal and distal ends are equal, and they're a little bit softer than the middle portion, which houses the valve. There's radiopaque markers, so you can see at the bottom of the leaflets. And there are 3 anchors for attachment and release, and you can see by the arrows that there's 2 of them here, and there's a 3rd one, and I'll show you during the loading. Currently, there are 3 valve sizes. There's a 20, 23, 26. There are 5 frame sizes, 1 frame for the 20, and 1 for the 23, 3 frame sizes for the 26 millimeter valve. And the way it's named is because it's symmetric, this diameter is the same proximal and distal, and you can see that it actually goes by about 4 millimeters, and here's the length of the frame. And what we found is that 2 new valves are being developed. They're 29 millimeter valves, and they're 48 millimeters in symmetric, and then only 48 millimeters long, and a 29 valve 52 millimeters in with the proximal and distal portions and a 50 millimeter length. This is the delivery system. It's 21 French. And you can see here, and one of the big things that happened that really improved the loading, you'll see right here, is because similar to the venous P valve, this is loaded in cold normal saline, so it can freeze your hands if you're in there a long time. And what we found was it was really hard to keep your hands so close together so that the 3 attachment could fall nicely. And you're going to see here in just a second, you can see that this right here, you can just keep your hand out of the water and you can just pinch this together. And what that does is that crimps the valve frame. You'll see that we'll pull that off. So as you get the attachment and move that out of the way, you can once you get this lined up with the 3 attachment recesses, once you're sure that it's there, then all you have to do now is pinch this, and that keeps this compressed. So now the second person who's now delivering the capsule to cover the device, and you can see there's a radiopaque marker, is easy. And so you can see it slips right over. You don't have to hold your hands there, and you just basically move down, and it continues to crimp the device as you load. This, when Sharon and I were first doing this in the animal lab, it'd take us about 20 plus minutes. Without this device, we asked the engineers to design this, and they did very quickly, and this now makes it 1 to 2 millimeters, 1 to 2 minutes, and you load the device, and there's the capsule. So next is the release, and similar to what you just saw, there's a rotation. You can do a very slow release, which you see here. If you want to slide, you can press this and slide it, but that's a faster delivery. This is very controlled. It's kind of in 3 parts. You can see this part, and here's where the valve is, and then here's the proximal portion as it's opened up. So what we did, animal studies, initially at Nationwide, we used sheep, and in China, they used pigs. This is some from our studies. You can see the release here, and here's where the valve is with the markers, and then the frame completely released, and here's the angiograms immediately post-release showing no pulmonary regurg or no perivalve leak. The registration clinical trial has been approved by the CFDA, just this most recent in April of this year. There's going to be 130 patients in 8 to 12 centers in China. But before the registration clinical trial, there were lots of requests, and with MedZenith getting approval, there have been a total now of 25 patients in 7 centers in China implanted before the clinical trial has begun, and we'll discuss these patients. So of these 25 patients you see here, which was between March in 2018 to May of 2020, you can see the weight and the ages from 14 to elderly at 67. Most of the patients had tetralogy flow. Most of the patients did not have a conduit. The device is probably better suited for patients with transannular patch, but there were 2 patients that had obstructed conduits that the device was placed. Here are the sites. You can see Wuhan had the majority, had the actually first implants, and they've done 18 of the 25, and you can see the other 6 sites here. The other thing that's important is that the larger of the devices, they're the 26 millimeter valve with 40 millimeter, 44 millimeter diameter proximal and distal frame. The majority of patients had those 2 frames, with the majority actually having the large, which again, is one of the reasons to develop a larger valve, larger frames. This was from the first implant in Wuhan. So this is actually the very first case in Wuhan, the 4426. So that's a 26 valve with 44 millimeter diameter was implanted. In this particular instance, you've heard a lot with the various speakers about how the patients or how the valve is chosen. From the CTA, systolic and diastolic average or perimeters, you can do either one in the RV outflow tract diameter and the PA, because that is the landing zone. Where the valve housing is, that does not touch the pulmonary artery. The landing zone is actually in the RV outflow tract proximally and just below the bifurcation. So this average systolic diastolic is used to choose the correct valve. Here's the very first implant, and you'll see the severe pulmonary regurgitation. And one of the things is a balloon testing for coronary compression is really not required for this particular device. It's symmetric design, so this area here where the coronary runs is not in contact actually with the pulmonary annulus or above the annulus. This is the echoes immediately afterwards, and then 1 year echo on this particular patient. You can see no pulmonary regurgitation and no significant perivalve leak. This was a case number 10 from another hospital in Beijing, Anjin Hospital. And again, this was the 4026, so it's the second largest of the frames. And here it is before, nice images, severe pulmonary regurgitation, and with the valve, nice 3D images as well. This was a case number 20. This was also from Wuhan. This was actually a live case that was being transmitted from Wuhan back to Shanghai during a structural heart disease conference. And quite honestly, you know, when they did some of the measurements, the largest valve looked a little bit small, but the guys thought they wanted to tackle this for a live case. I was a little bit reticent, but you can see severe pulmonary regurgitation here, the picture in the MPA showing regurgitation. So what they asked me to do was, would I go ahead and just kind of proctor moderate by Zoom? So you'll see here.
That's RV, and then we'll do the PA.
So the device came down a little bit, but you see it's very nice. That's why we were a little worried. The size, I think the newer valve size and frame size would be even better, but that worked out very nicely in this particular patient. And you can see afterwards had very nice results with no significant stenosis and no pulmonary regurg. This is the last patient I wanted to show this, and this was a patient, one of the patients that had obstruction of RV to PA conduit, had stenosis as well as severe regurgitation. I'm a little hesitant to kind of advertise this particular device in conduits, but this particular, you can see here, this was the smallest device. It's a 20 millimeter valve, 28 millimeter diameter at the proximal and distal end. And so this was the pre-implant. You can kind of see, get an idea, this is where the stenosis is going to be, like many of the homographs. And after this, after the PT valve was in, they decided to balloon dilate with a 20 millimeter NewMed balloon, which is the size of the valve. And you can see afterwards, there's no significant pulmonary regurgitation. And when you look over here at the Doppler recording, you can see there's only about a 17 millimeter peak instantaneous gradient. So it actually did its job. So the results and the serious adverse events so far, there have been 25 of 25 successful implants. There's been no device embolizations, no significant arrhythmias requiring treatment. There have been no erosions, no surgical explants so far, and there's been no repeat transcatheter interventions in these first 25 patients and no endocarditis reported. These are the results so far of the patients that have reached certain endpoints. And you can see most everybody had severe pulmonary regurgitation. Some had pulmonary stenosis, but then at the 1 year mark, the majority of patients that have been studied so far have no pulmonary regurgitation. And as far as gradient, the reason this is a little higher than what you would expect with patients with severe pulmonary regurgitation, because this includes 2 patients with obstructed conduits. And there were several patients that had subpulmonary stenosis. That's why this is higher than really we would think it should be. But you can see in follow-up that the gradients have been low and remain low, at least at 1 year out. So in conclusion, certainly the early results of the MedZenith PT valve for severe pulmonary regurgitation are promising. An experienced proctor, which I guess that was me, was present for the first implant, but the other 24 implants by different implanters at different sites were performed without an experienced proctor present, which I think demonstrates the ease of use. And as I showed you once, the proctor me even used Zoom for a live case. So the results so far compare favorably with the other devices you've heard so far, which is the Harmony, Altera, Venus P, and Pulsta. The two largest available PT valves were used in 15 of the 25 cases. However, two larger valve sizes and frames are being developed. And I mentioned the 29 millimeter valve with larger frames that are shorter. And the registration clinical trial is set to begin in China approximately August of this year. Thank you, and I wanted to thank all of the implanters at the 7 institutions in China, as well as those that have worked at MedZenith, all the engineers.
All right, John, thanks a lot. Thank you for this great talk. So we saved the best for last. The last device to be used for native outflow tract will be discussed by Dr. Shabana Shanavaz from WashU. Shabana is a great rising star in interventional cardiology. She's going to talk to us about the Altera and Sapien 3. Shabana. Are you mute? Shabana, unmute.
Sorry about that. I was just thanking the moderators. I think that was Evan intervening so that he could speak. He tried to sabotage me several times.
Good. Go ahead.
I'm going to speak about the Altera device. Thank you for that introduction. These are my disclosures. I'm a proctor and consultant for Edwards Life Sciences. So the Altera pre-stent is very different from some of the other native RVOT valves that has been discussed. It actually is a docking system that's been made that reduces and reconfigures the RVOT from the inside. Unlike the other valves, it is made to work with the Sapien 3 valve, which is a 29 millimeter Sapien 3 valve itself, and you see the mechanism work really nicely there. A little bit about the Altera frame itself. It's a self-expanding nitinol frame. It has a symmetric design, 47 millimeters at the most expanded part. The valve housing, which is the center portion you see there, it's 27 millimeters in length. And what's also, going back to that, what's also interesting is the distal end of this valve is not covered, around about 10 millimeters of that, so which gives you nice leeway into the branch pulmonary arteries, especially in patients who have a shorter RVOT. The whole covered portion is covered by PET, and it comes preloaded, which is also another nice thing in a delivery system, which is very similar to the other delivery system. It's a self-expanding system, so it has a nice control knob that you just turn counterclockwise, can very well slow release of the device. It has a retractable sheath, as you see, at a radio opaque marker in the distal portion. Now, the anatomical substrate you need for this is in any RVOT systolic diameter greater than 27 millimeters and less than 38 millimeters, and an RVOT length that's greater than 35 millimeters. That's from the takeoff of the branch pulmonary arteries to the inflow portion of the RV, or what we, sorry, outflow portion of the RV, or what we call as a contractile portion of the RV. And that's something we look very carefully as we evaluate the RVOTs before patient selection. So I'll go through a case and then talk about the device properties as it pertains to this case. This is one of our first cases we did here. A 16-year-old female who had valvular PS and a perimembranous VSD, had patch closure of a VSD and a pulmonary valvotomy. Ended up having severe PI and was symptomatic. This was her MRI with an dilated RV, normal RVEF, and normal LVEF. And you see there nicely dilated RVOT. She was initially brought to the cardiac cath lab based on that MRI for standard transcatheter valve placement with a 29mm Sapien. Her angiography demonstrated it was no stenosis at all, nice, good sized branch pulmonary arteries. We at the time balloon size, and this was pre-selection of the Altera, or of her being a candidate for the Altera itself. So for the Altera study device placement, you do not need balloon sizing. So once we did that, our choices were to A, send her to surgery, or B, push the limits of putting a Sapien in, or C, just wait for the Altera device, which is what we did at the time. So the process these patients go through, it's a 4-step process from RVOT measurement to 3D printed model. You get a gated CT that evaluates both the RVOT and the main pulmonary artery. They create perimeter plots looking at how the Altera sits within the RVOT itself. Virtual implants are created, and 3D models are made based on these measurements. So I'll go through the process for this patient itself. So this is what the core lab does in terms of looking at the gated CT. The important distances we look at is the takeoff of the PA to RV contractile tissue in this patient was 50. In systole and diastole, we look at both. What we have seen as the systolic model is pretty consistent in what happens in the patient itself. We also look at the annular plane to first branch PA takeoff, and the importance of that is if the patient has any valve tissue, we'd like to cover that with the device itself so that there is no impingement or partial impingement of the valve that causes obstruction right in the RVOT. This is the perimeter plot. Matt went through that really nicely, but again, what we look for is this green zone that you see right there for the patient to be selected as an trial patient. We look at both systolic and diastolic models. Again, we have seen that the systolic models are very predictive of what we see the ultimate device placement is. So this is the virtual implant that happens. Again, all of that is done with the core lab and evaluated with every case. And this is with the device, so both systolic and diastolic models itself. In this patient, although we saw this raised, we saw that the balloon of that measured to be 30 millimeters. We decided a good place to implant that would be away from the contractile tissue in the regular annular portion. The things we look at is any chance of perivalvar or para-Altera leak, and that's something you look at with this model. So this is a polyjet model, again, made for all patients. This is where you would see in the RPA, this would look like. You also see the calcium that's in the RVOT. This is imaged really well and evaluated to see from the inflow portion if there's going to be any chances of para-Altera leak. Then all of these patients undergo a virtual implant, and this is how the device gets positioned and released under fluoroscopy. And actually, this is exactly how the device behaves in the patient. It is very slow, can be very controlled, and you can position the device exactly where you want it with a need for minimal movement. Again, the polyjet models, you look both in systole and diastole and decide device positioning. So this, based on all of this information, looked like the candidate would be a great candidate to go and get an Altera place. So like all of these self-expanding devices, when we do this, we do it with biplane fluoroscopy with intermittent angiograms. We start with flowering it in one of the branch PAs, depending on what the anatomy looks like. Most of us, our deployments have been in the LPA, but I'll also go through an RPA deployment. So this is 1/3 of the device that's been released, looks good, is a little in the PA, but as it gets opened up a little more, you'll see that this is flowered really nicely to be positioned exactly how the model looks like into the RPA, especially on the lateral panel. Here you see it nicely opened up in the RPA without causing impingement. Now, the other thing to remember is the distal 10 millimeters is uncovered. So even if it is a little further into the branch pulmonary arteries, the concern for complete occlusion of the PA is going to be really low. So this is complete deployment, and an injection shows great placement like we wanted. In the main pulmonary artery itself is nice and expanded. It does take a few minutes to expand. So for most of the less patient interventionalists, I not being one of those people, you have to wait a few minutes to look at the full expansion, especially in the inflow portion. The other thing with all of these devices, as we pull the delivery system out, you have to make sure that you're not distorting the distal frame of the Altera itself. Now the Sapien goes standard through the commander delivery system. We centered it right at this docking area, right in the center where the marker bands are, and standard deployment with their delivery system itself. Obviously the Sapien, the commander delivery system currently is what's available commercially, but for the last few patients in the trial, we have been able to use the covered system that works phenomenally in these patients. So once this Sapien got delivered in this particular patient, you see no PI, unobstructed branch pulmonary arteries, and good device placement itself. So this is the ICE imaging, the Nyquist still being low. You don't see any valvar regurgitation. We also do a complete evaluation looking for the para-Altera leak. You see a little bit of para-Altera leak. This is the lateral aspect, and maybe a speck on the medial aspect. That's another thing we look at in all of these patients. And what we have seen is most of these leaks, although minimal, go away within the first post-op day. So we have not seen any significant para-Altera leak in these patients. So the best part of this device in my mind is the ability to recapture. This is a patient we attempted to deploy the device from the LPA, but as we were deploying it, it seemed really not sit well. Now this is the same patient. We started recapturing the device and then deploy it from the LPA itself. And once we deployed, the RPA, and once we deployed it, released it from the RPA, and then you see in the rightmost panel post-deployment from the RPA, it sits much better. So one of the things we have learned is paying close attention to the models to see what actually PA, no different from how you would evaluate a standard transcatheter valve placement in these patients itself in terms of positioning of wires in the branch pulmonary. So the Altera early feasibility trial has been completed. It was a single-arm multi-center study with follow-up up to 5 years. There were 4 sites that were initially enrolling these patients. The primary endpoint was an implant success. Now, this particular trial allowed for staged procedures, but every single patient in the trial ended up having both the pre-stent and the valve deployed during the same procedure, so not in a staged approach. All of these patients also had met their primary and secondary endpoint criteria with minimal PI. The inclusion criteria was a weight less than greater than 20 kilos and the usual of dysfunctional RVOT and the measurements that I already stated in terms of length and diameter. This is the feasibility chart. So 29 patients were initially consented, 14 screen fails. 2 of them ended up having a really small RVOT. So ended up getting standard implantation. So 12 true screen fails, out of which 2 patients end up getting the Altera device in the next phase of the trial. Now, 1 patient was a screen fail just because she ended up showing up pregnant on her day of the cardiac catheterization itself. But of the patients that were catheterized, all 15 were implanted on the same day and 6-month follow-up was completed. And device implant success was achieved in 100% with no major complications, no mortality, and minimal dysfunction at 30 days and 6-month follow-up. Now, the pivotal trial has also been successfully completed with 60 patients enrolled at 11 sites. And actually, Evan's going to be presenting that at the PICS meeting. So we'll wait for the results on that. So in conclusion, the Altera is a self-expanding device that internally reconfigures the RVOT. It's made to be a docking system for the 29mm Sapien. It also has no covering on the distal end and can be recaptured up to the first 50% of the pre-stent being deployed. Now, the early results, both safety and effectiveness have been established. We'll just wait for the long term of that. Acknowledgements again to Evan now for including me in this and for everything he's done for this trial. Thank you.
Thank you, Shabana. Thanks a lot to all the speakers for this part of this session. I'm going to give the microphone to Grace. She has, some questions from the audience. Grace.
We have some questions that the speakers sent to us. So the first one is from Dr. Shabana. If you can ask the audience about your question.
So choose the correct one. The Altera pre-stent is a completely covered valve stent. It's designed as a docking system for the valve. It has an asymmetrical design with a larger inflow than outflow. The device cannot be recaptured once initially deployed, and it's covered by PTFE versus the PET membrane.
Okay, let's wait a little bit for everybody to answer. And we have a couple of more questions. And after that, we can open to discussion. There are some very interesting questions on the Q&A, and some of them we are going to answer live. So if you have one question, please, you can type on the Q&A and we are going to try to answer you. Okay, so that's the result.
Oh,
can you see it?
I don't actually, oh yeah, I do see it now. Yes, B is correct. It is designed to be a docking system for the 29mm Sapien valve.
Perfect. So we have one more. Dr. Sheeta?
Yes, so all of the below are true except, these were always I hated these questions when I used to take tests for real. So the one that is not true for the PT valve, the Medzine's PT valve, the valve is porcine pericardial valve. The frame is comprised of nitinol and is self-expandable and covered with porcine pericardium. Balloon testing is required to evaluate for coronary compression prior to implant. Currently, there are 3 valve sizes and 5 frame dimensions to choose from. The CFDA recently approved a registration clinical study to be carried out in 8 to 12 centers in China in 130 patients. So choose the statement that is incorrect.
Okay, let's take a look.
So, yes, so 60% gave the correct answer, which the incorrect answer. Balloon testing is required to evaluate coronary compression. That's not, you do not have to do balloon testing for coronary compression, which is, which is different from the venous P valve. And also for I think the Altera, you do balloon sizing. I'm assuming you look at the coronaries when you're doing, since you're putting in the Sapien. And I don't know about Dr. Kim, whether they
actually, John, we don't.
Okay.
Balloon sizing is not really part of it, and we don't look for coronary compression.
Okay, good. So unlike the normal S3, and is that because you're placing it supraannular? Because I noticed that it's always above the pulmonary valve.
No, it's because when the engineers tested the device, it doesn't have enough. We don't believe it has enough radial strength where it attaches to cause coronary compression. It's really more of an affixation of the apices than a radial force external compression. So we don't think you have to test.
Good.
And the Sapien itself is sort of sitting in space in the docking station, so that part shouldn't compress anything.
Yeah. And because I wanted to ask Dr. Kim the last time he gave his lecture, what about the pulsed valve? I know so you did your sizing based on multiple echo, CT, MRI, and took the mean of those. Is that how you choose? You don't do any balloon sizing?
Yes, so we usually do balloon sizing to see the main pulmonary dilatability and also do the coronary compression. So for example, today I had one case. So when I did the balloon sizing, 34 millimeter cocoon sizing balloon, the left coronary LAD was compressed. So I did not input the pulsed valve because the radial force pulsed valve is stronger than sizing balloon. So I think after CT scan, suspicious of coronary near to the main PA landing zone, balloon sizing is very important to see coronary compression.
Yeah, I think the reason I'm bringing this up and wanted to ask this question, and Z can comment on the venous P, is because each of these valves so far and frames are designed a little differently. So we have to be cognizant of which one you're using, and for safety purposes, not only sizing. And Z, you can comment about the venous P again, because that's where
I still do balloon sizing for the venous P valve, as well as for other valves that we use, the Melody and the Edwards. So I think it's a good practice to do it. But if the PT valve and the Altera, they don't, that's an added advantage.
Okay, there's one question from the audience, from Rigoberto, about anticoagulation or anti-aggregation on these devices. Can you comment on that?
Well, I'll start with the venous P valve. It's, we just give aspirin. We don't use any other anticoagulants.
For this, I mean,
I think it's, I just want to say it's a really important question, because I'm at a center that does a tremendous amount of TAVR work, and really we're early on to describe the microthrombi that they see on the leaflets before there was any clinical problem. And then a few years later, they started noticing patients with a certain pattern of microthrombi did develop clinical stenosis of the leaflets. And now that's you can see this on CT with a proper protocol. And now that's a huge area of exploration in TAVR. And in fact, just this week, we approached Edwards to see if we can start to look at least the Sapien valve, whether it's in an Altera or just in a native RVOT, what is going on there in terms of, are we seeing microthrombi? And I think it would behoove all of us. I mean, all of these valves are different. Dr. Kim has his own method for processing the pulse and so on and so forth. But there's no reason that these valve leaflets of any of these valves will be immune from the potential for microthrombi, microemboli. And I think as we, the first step is getting them in there and learning that they work. And that's what all these talks are. The next step, I think it will be important to look at leaflet function down the line, particularly in a low pressure system like the pulmonic system. So I think it's a really timely and important question.
Hey, Evan, can I ask a question then? Because you mentioned earlier, just now, that on the TAVR, they were looking at some of the CT data to show some of the micro. So does that mean you will likely need to do post-implant CTs on the patients, because the others don't really show, the other modalities don't show this so well?
Yeah, I think, and I'm no expert in this area, but I started really delving into it literally just this week. I think so, John. From what I can tell, the best modality at this point to evaluate is CT. At least in the Altera protocol, I'm not sure about the other ones. I think in Harmony, we're doing CTs as part of the protocol anyway. So it's not really, it might be a good population to begin to look at this if we can get the protocols, and maybe you need to add a certain sequence or something, but it's not a lot. And that would certainly give us, and the way this came about, by the way, is one of our CT guys who sees TAVRs all day called us about an Altera patient. He said, and said, we're seeing some of the things, the valve's fine, the echo's fine, there's no gradient, but we're seeing a little of these microthrombi that we see in the aortic position. Is this of concern? And our answer was, we have no idea, and which made me think we really need to probably begin to take a look at this.
Yeah, the only thing I can say, and you know this, Evan, in the early feasibility study for the Harmony, post-implant CTs were required within 4 to 5 days, accounting for discharge over the weekend, and mainly though to look at the frame and how it works and everything. But from that the preliminary data, just from those 20 patients, we didn't see anything on the valves. But that was just within the first 4 or 5 days. We did do CTs in the Harmony in 2 years in the post-implant for a different reason. And again, microthrombi or anything were not seen on the valve, although because of the material and everything, there's a slight ingrowth, not significant, but slight ingrowth. And as you know, right now, I think we're just in the Harmony, and Matt could, so we're just doing aspirin, and the same thing in China for the PT valve, although I'm not sure if that's right or wrong.
The other area that we might have to think about is in relation to microthrombi. Is endocarditis, isn't it? Because there have been issues and concerns with different types of valves and endocarditis, and whether they're related to microthrombi, and whether antiplatelets should be given in the long term, and also dual antiplatelets or single antiplatelets. So there are quite a few unanswered questions in relation to that.
So we're just looking at a series of 700 odd patients with the Sapien valve. And what we have seen is there have been a few cases in which there were valve dysfunction that was identified, and patients anticoagulated with improved valve function. The other thing we have also started to see with that series, with just a median follow-up of 2 years, is in these larger valves, the 29 millimeter valves in the native RVOT position, there's a little more dysfunction than you would expect for the Sapien valve itself. So one of my questions and concern was, what's that related to microthrombi? Obviously, I don't have any data to know that, but that's certainly in the long term one of the questions we'll be focusing on.
So isn't it not true for surgery, for surgical tissue valves in the pulmonary? They in fact are giving either anticoagulation, antiplatelet, or dual antiplatelet is recommended. Is that not correct? When they put a surgical tissue valve in now?
At our center, at least, they've just done aspirin. Now, I know at a previous center I was at, they would definitely in about teenage years do aspirin and Plavix.
Yeah, the only reason I say, I think they're coming out with recommendations. I think that's what most of the surgeons are now going to. And I think, like Shaq said, I think ultimately we'll end up with either dual antiplatelet therapy for X number period afterwards. And whether it's anticoagulation, antiplatelet, that might be hard in some of the patients. But I do think we'll probably end up with dual antiplatelet for a short period of time. And then, like we all do, aspirin. It always bothers me with the aspirin, since 50% of patients do not respond to aspirin with its antiplatelet properties. So it's a little bit of an issue, I think, but we'll see, I guess.
Okay. Any other questions from the panelists, from the speakers? Do you want to comment something else? So if not, I just needed to give a quick announcement, and then Dr. Zahn can wrap up our meeting. So for Congenital Heart Academy, what we are going to have for the next few weeks. So tomorrow we have a very nice talk with Dr. Robert Anderson about the morphology of the ASD, and we are happy to announce that Dr. Anderson is going to continue to do these classrooms, at least 2 more, AVSD on 3rd of July and VSD on the 10th of July. We're very happy for that. And we are going to have next Thursday, the 2nd of July, in the same time, we are going to have the transposition of great arteries, part 2. For the part 1, we have more than 2,000 people watching and more than 4,000 people that already watched on YouTube. So we are very happy for that. So we are going to talk about follow-up after arterial switch. It's going to be a very nice session. And on the next Thursday after that, on the 9th of July, we are going to have the ECMO part 2. We had more than 1,800 people attending the first one, and already more than 2,000 people watched on YouTube the ECMO first part. We are going to have the second part go a little bit away from the cardiac and go talk a little bit more respiratory and other things like how to build an ECMO program, anticoagulation, and research. Please follow us on social media. This is our email. It's open for all of you, and we are going to send you by email, but if you could please fill our survey. We want to improve. We want to see how you think about our meeting. Dr. Zahn?
I just want to say in closing that, you know, we all go to a lot of meetings. Obviously, they're a lot more fun when you can see your colleagues and go to the bar after the session. But having said that, the talks today were just phenomenally good, really cutting edge, really well put together. And that doesn't come without a lot of effort. So I want to really extend my thank you to really a world-class group of interventional cardiologists who joined us today. And then most importantly, I really want to thank Sasha and Gil and Grace. This academy learning is just a phenomenal thing. I think during these COVID strange times, we're all desperate to see and hear our colleagues and to gain as much new information as we can. And this is such a phenomenal teaching tool. So thank you so much for coming up with this. And on a personal note, I really want to thank Sasha for allowing me to be involved and having me here today with all of my colleagues. Thank you.
Thank you. Bye-bye.
We really, really liked it. And Gil apologize. He's on clinical service this week. He was not able to be with us, but he's watching on YouTube. And thank all of you from Congenital Heart Academy. You are part of our family, and we are very, very happy to have you. And this meeting was amazing. Thank you very much.
Thank you very much.
Thank you. Thanks, guys. Take care. Thank you.
Bye. Please stay safe.
Bye. Bye-bye.
Ciao Giulia, grazie.